I want to thank you all so very much for being here. Here being the 32nd annual Florida Debates Decisions Solutions Conference. My name is Ken Goodman. I'm a professor at the University of Miami, where I direct our Institute for Bioethics and Health Policy, and I'm the happy director of the Florida Bioethics Network. In years past, we would have spent goodness knows how much time acknowledging sponsors. What you're noticing this year is that we haven't asked you for money. As the FBN evolves, we're trying to make it so that it's easy and free for all people in Florida who have an interest in bioethics to be able to participate in our activities. Some of this is an accommodation, a post-COVID accommodation, and some of it is just the idea that we want to make this a little easier than it used to be. The institutions that help found, sustain, and encourage the flourishing of the FBN are still acknowledged on our website. Many of them are still represented in this room, and I thank you. I want to begin, though, with other thanks, most noteworthily to Anna and Esther Galliera, Anna Bezzanilla, our administrative support at the University of Miami. They're the ones who have been pulling it all together and who have for several years in public. Anna and Esther, thank you so very much. What I'd like to do, now that I've seen Ray here, is acknowledge Ray Mosley, the founder of the Florida Bioethics Network, and make sure you know the names of the board members, which are also on the website. Many of them are here, and I want you to notice something about the diversity of this group. I will read their names. Dave Anderson, Faith Baptist Church in Sarasota, Stu Bagatelle, JFK Medical Center, Atlantis, Laurel Clark, Cleveland Clinic Weston, Karen Coleman, Barry University, Miami, Greg Dickinson, Sarasota Memorial, Lou Garballo, University of Central Florida, Marin Gillis. Marin is now in Las Vegas. She's left Florida, but she did so much work for this organization, including on some really special projects, and I have not got the heart to remove her. Marty Gleiber from Florida Atlantic University, Becky Martinez, Florida International University, Hannah Osmond, retiring with distinction from the University of South Florida, Marnie Ponce, RNJD, of the law firm in Jupiter, and one of the nurse lawyers. We had a couple of those nurse lawyers here, don't we, Kathy? Alyssa Swota from Wolfson Children's in Jacksonville, and Baptist Health. Davis Tornabetti in Sarasota, Shalonda Triplett from the Institute for Successful Learning in Orlando. What I wanted you to notice is there are clergy, there are physicians, there are nurses, there are lawyers. Even let Ray and Ken in, the philosophers of the gang. What that signals, I think, is what we've been trying to do, and I think it captures the part of at least the vision of our founder, to provide for the people of the state of Florida robust, ongoing, high-quality ethics education and support. That support in the vision of the network was not a little upended during COVID. What networking means these days is evolving quickly. If anybody here knows how to dance, maybe we could do a TikTok video. I'm not sure about that sort of thing. But the idea is that in this United States of America's third most populous state, with apparently more clinicians per square meter than anywhere, we have an opportunity. Florida, as you know, has been in the news lately. It's been in the national news and the international news because of various, how should we say, health ethics issues. You have opinion on these things. We've debated these issues in this conference over the past more than 3 decades. What I think is uncontroversial is that what we try and do, and I think on balance have done a fair job succeeding, is provide a forum for all kinds of views, to provide an opportunity for professional development, and to provide additional opportunities for us to try and meet and stay in touch with each other. So I mentioned Alyssa Swota, her November conference on pediatric bioethics is now in its, well, Alyssa, if you're here, was it a decade and a half? We are sustainable in part because of you, because there's a need for this, and because we want to be able to continue to meet the need. You've also, in addition to not asking you for money for anything, we're also by the same token, asking you for support. Shout out to Glenn Singer at Broward General. Glenn's been doing ethics rounds there for many, many years. We now share them with people around the state. They are free, and the tradition at Broward General has been an extraordinary opportunity for speakers, noteworthy national speakers, Also to Rabbi Dr. Kogan from Baptist Health of South Florida. Their Conversations in Ethics, which goes back more than 20 years, is also now shared with the FBN. Some of the things we do at UM, we share. If your institution is doing an ethics activity or wants help with an ethics activity, please let us know. What we're trying to do is have a network that is a little more decentralized. We realize that there are many colleagues in the Panhandle who are just not driving to conferences in Miami much these days. We want to be able to be there. Florida is a very, very large and peculiarly shaped state. From Key West to Pensacola is quite a drive, I'm told. But that's an opportunity for us. We have lots of differences of opinion, but unanimity on the following. Contemporary health professionals, if they are to be successful, if they are to actually walk the walk that signals those values of patient-centeredness, of justice and equity. I hope I'm still allowed to say those words in Florida. Why then this is your venue. The fact of the matter is we are able to acknowledge differences among us, but what we all get to teach our students is that disagreement is good. Disagreement can confer respect. Respectful disagreement is the lifeblood of civil society. And I think thanks to Ray's vision, we've actually been able to accomplish that in some part. We have what I think is a very exciting program. And I will begin by introducing our first speaker. Unless, by the way, Ray, have I omitted anything that you'd like to add? Have I made any mistakes yet?
Not a one.
You know, it's funny. Now I'm going to have an emo moment on you, Ray. When I returned to Miami 32 years ago, driving down, doesn't matter from where, Pittsburgh, I thought I'm going to pull off I-75 and see who's doing ethics at the University of Florida. Those of us who get to work in healthcare or in academia have all kinds of different relationships, and some of them last more or less, as the project requires. But Ray, I've just had the hypothesis that in terms of academic collaborations, especially between our two institutions, the University of Florida, the flagship university of the state university system, and the University of Miami, private university, at the state's first medical school. But while we make jokes about that, Ray, what you and I have accomplished in academia in the state of Florida is a relationship that is now in its 4th decade. That's kind of cool. Here's to you. So Dr. Hendry, you see, we're not shy of emo here every once in a while on the Florida Bioethics Network. It is my pleasure and privilege now to introduce you to our first presenter of the 32nd Annual Conference, Florida Ethics Debates, Decisions, Solutions, by which I mean Dr. Phyllis Hendry. She's Professor of Emergency Medicine and Pediatrics and Associate Chair for Research in the Department of Emergency Medicine, the University of Florida College of Medicine in Jacksonville. Yes, the UF has grown and has campuses all over the place, and Dr. Hendry joins us from Jacksonville. In addition to that, she's Florida EMS for Children Project and Medical Director. As many of you who are regulars here know, we in the FBN have emphasized a number of issues over the past several years. And one of them I mentioned earlier was pediatrics in Dr. Swota's program in Jacksonville, first Friday of November. But the other has been crisis standards of care. The FBN spent a lot of time working with colleagues around the state on crisis standards during COVID and for other reasons. And what I've learned from Dr. Hendry is that while we're talking about crisis standards, her work and the work of her organization is absolutely essential for making sure that we are, when we're talking about preparedness, actually doing what needs to be done. On that note, Dr. Hendry, the floor is yours. Thank you so very much for joining us today.
Thank you for the invitation. I'm going to go ahead and share my screen. And okay. Can everyone see the first slide? Great.
We're good.
Okay, good. Okay, so this is the topic. I'm going to be talking to you about pediatric emergency care and everyday readiness. And you've already heard my introduction. I wear a lot of different hats, but my favorite hat I wear is the Florida EMS for Children program, which I've worked with since I think the 1990s. And you'll hear the term and see Florida Ped Ready. So Florida EMS for Children is the same thing as Florida Ped Ready. It is a HRSA-funded program, and I'm going to tell you a little bit about the program background, and then go into some cases and some challenges and solutions. So I have no financial disclosures, and yes, the history behind this presentation is that I met Ken when I was speaking at a Healthcare Coalition meeting in Miami. So when I did this talk is kind of based on emergency preparedness, but I tried to tweak it a little bit for today. So I'm not sure if any of you know this gentleman and what he did for children, but he demonstrates what one person can do when we're passionate about something. So I always like to, just get this out of the way. I always like to use him as an example. So he was a senator from Hawaii, and he is really the father of EMS for Children. And he was able to get, along with some of his buddies, legislation enacted in 1994 that started the EMS for Children program. It's under the administration of HRSA, Maternal Child Health Bureau. But you ask, why did he do this? I actually was just kind of looking him up last night, his history. He was a decorated World War II veteran, did many wonderful things, of which EMSC was just one tiny little piece. But the reason he did this is because he had a staff assistant and chief of staff who had a daughter. They were in the DC area. She became ill, had some viral type symptoms. They really just went to the local emergency department, didn't really know where to go. And let's just say she didn't get the best of care, actually had meningitis, almost died. And he said, this is an outrage. We really got to change the care for children. And you have to remember at that time, the focus in the country was on ACLS, trauma care. There was very little focus on pediatric care. So what is the mission of the EMS for Children program? It's to, reduce morbidity and mortality. But the key is that when you hear EMS, you may think that, you're only talking about ambulances, but we're really talking about the full continuum of care. So what happens at dispatch? What happens in the back of an ambulance? What happens in our emergency department when the child's admitted? When they go home, their mental health, and then how do we prevent all these things from happening? So we're not trying to create a separate system. What we're trying to do is just enhance the existing system that we have and make sure it includes children. So I know this is probably a little bit difficult to see, but just to give you a little brief history, because EMS for Children includes a lot of different programs. So there are state partnership programs, which is what I'm involved in. They have an EMSC data center, which is housed at University of Utah. Many of you, if you practice clinically, may have heard of PECARN, Pediatric Emergency Care Applied Research Network. That was a major accomplishment because there are very few critically ill children. So how do you do studies? So these are large networks that include children's hospitals and community EDs. Then the whole concept of pediatric readiness was started in 2012 with emergency departments. And then now in 2019, that same focus was put on a pre-hospital pediatric readiness project. And then during the pandemic, we realized, hey, we're not very prepared for children in a pandemic or in a disaster setting. So additional funds have been put into this program. And I don't know the exact amount. I tried to look, but I think it's about $30 million a year that Congress allocates to the program. So this just kind of shows you all these programs. And then this is what I'm focused on, what's happening at a local level. So if you look at the bottom of the slide, these are the supporting organizations: AAP, American College of Emergency Physicians, Emergency Nursing Association, American College of Surgeons, and National Association of EMS Officials. So it's truly a cross-cultural, multidisciplinary collaboration. And adding American College of Surgeons is new to the table. Believe it or not, there are level 2 trauma centers, non-pediatric trauma centers that really weren't prepared for children. And so they're added to the table. And then we have this new focus now on disaster preparedness. We have performance measures that we have to meet to get our funding, which is not a lot of funding. I'll get to that in a minute. So basically, for emergency departments and EMS agencies, we're trying to make sure they have pediatric readiness. They would like for us to have a state pediatric readiness recognition program for EDs and EMS. That's very hard to do if you don't have legislation to back you up. So we're trying to start that now, and it'll be on a voluntary basis. But a term you may not be familiar with is called a PEC, Pediatric Emergency Care Coordinator or Champion. And we'll talk more about that, but that is a term you'll be hearing more in the future. It's not a new position, but the data and the literature is showing that having just someone designated in your ED and in your EMS agency will improve pediatric care. And then we always prioritize family partnerships. So with that being said, with those requirements, this is our mission statement, and I won't read it to you. I'll let you, I think it speaks for itself. So just a little bit about Florida. As was mentioned earlier, we are the third most populous state in the US. However, we receive the same amount of funding as Maine or Rhode Island, even though we have 320 EMS agencies and 335 emergency departments. And our freestanding emergency departments are rapidly multiplying. It's like CVS and Walgreens. There's almost one on every corner now. In 1997, there was legislation enacted to establish a Florida EMSC Advisory Committee, and we meet quarterly along with our other state EMS Advisory Council members, and I'll be showing you our membership in a few moments. The program was moved administratively to UF under my department that I oversee April 1st, 2023. So we just had our first university. First anniversary, not university. To have the program, you have to be a state college of medicine or university-based college of medicine, or you have to be in the branch of state government that houses the EMS office. So we work very collaboratively with our state Bureau of Emergency Medical Oversight, and they requested that we move the program. And I would say there's pros and cons in the different states, whether you're with the university or with the state Department of Health. So again, we're trying to ensure the entire continuum of care is pediatric ready. And to do this, we're working very closely with our Florida healthcare coalitions, the different regions here. And I'll show you in a few moments why that is so important. So you might be saying, okay, this is boring. I don't really take care of kids. That's why we have children's hospitals, or, I don't have children. Children are rarely sick. I know you're all from very different backgrounds. This topic really isn't relative to me. So I want to show you why I think the topic is relative to everyone. If you ask, and many of you know this because of this reason you're on this conference today, what is one of the most stressful emotional situations for emergency physicians, other physicians, nurses, paramedics, teachers, maybe a bystander? It is caring for a critically ill child. It is watching a child die. It's having to deliver bad news to a family. And maybe you're not a healthcare professional. Maybe you're at a state park and you happen to see a child drowning in the water. You're driving to work and a child darts out in front of you or in front of another car on their bicycle and is hit by a car. You're going to work and you see a bus that goes off of a bridge filled with parents and children. Maybe a school in your area has an active shooter event, which we know has happened in Florida and is happening almost every week across the country. A real case, a mother's in a car at a bank drive-through when she's hijacked by someone robbing the bank, and law enforcement accidentally shoots the child they don't know is in the car. Or maybe you supervise someone who made a significant medication or other medical error. Or maybe you're married to someone or live with someone or have a friend who's gone through one of these scenarios. And we know that this can lead to post-traumatic stress symptoms, depression, sleep disturbances, suicide. So how we deal with these topics is very important. So again, this could be your village, your child, your grandchild, your neighbor. And even though we don't have a large volume of critically ill and injured children, it is very high emotional burden, high risk situations. So for example, in Hurricane Ian, that hurricane turned quickly. The Fort Myers area was not expecting what they got. And suddenly they had to evacuate, forgot the exact number, 75 or 80 critically ill children and neonates in 24 hours. And if we look at other recent MCIs and disasters, children don't always show up at the Children's Hospital or the trauma center. And I think what we're seeing every day in our country is that you just can't predict what's going to happen. So I'm often asked, well, what's the difference between pediatric readiness and disaster preparedness? And I would say it's the same. So if we can't be ready every day, then we can't be ready on that big game day when there's a disaster. So if you can't take care of 4 critically ill injured children right now today, then you certainly can't take care of them during a crisis situation. And I have a couple of case scenarios I'm just going to go over briefly that I think bring up some of the challenges we have in children. I don't know how she came for me, but my daughter was actually a barrel horse racer and attended all kinds of national events. So I would have to drive a horse trailer. So this is a case where there was a mother driving her young daughters home at night after a horse show, pulling a loaded horse trailer at night in a rural area. It's foggy and wet. Another motorist finds the truck and trailer overturned on the side of a 2-lane road and calls 911. Mother's unconscious. Both children and 2 horses are critically injured, and one of the children are in cardiac arrest. Unfortunately, in this rural county, there's only one active advanced life support unit for the entire county. And guess what? They're dealing with someone that's having a stroke. So it takes them 20 to 30 minutes to arrive. And paramedics work 24-hour shifts. So they're on the hour 20 of their shift. And all of these patients need to go to a trauma center, a state designated or ACS verified trauma center. And that is over an hour away in the current weather conditions. And you can't call the wonderful helicopter life flight service to come pick them up because of the weather. They're resuscitating the child. And remember, they requested some more advanced pediatric equipment, but this rural county did not have the funding. So this entire family is transported to the closest community ED that's staffed with 1 locum tenens doctor who doesn't really know the area, and 2 nurses. And all of these have to be transported. But how long will that take? It may take 2 hours for that to happen. Meanwhile, an urban scenario, which is more of where I work in Jacksonville, there's a car accident in the evening, 5 to 10 minutes away from a level 1 trauma center, where you have a scenario where you have multiple people available. You have respiratory therapists, you have trauma surgeons, you have emergency physicians, pediatric emergency physicians. You get a report, there are 4 children in the van. They're all critically injured, but 2 of them are in cardiac arrest. And you have to think about, where are you going to get? How are you going to prepare for multiple patients? Where are you going to find multiple sets of pediatric and adult equipment? So even in a level 1 trauma center, this is challenging. How are you going to register a child when you don't even know their name or age because their parents are also injured? So just thinking about that, let's talk about some of the differences between children and adults. And this is in any case, but also in an emergency situation. So 1, we have to deal with everything from a 2-kilogram premature baby to maybe a 300 or 400 pound adolescent. Children have, we could spend a whole hour talking about the different anatomical and physiologic differences, but they have differences in their anatomy and their physiologic responses. Their injury mechanisms are different. Children put everything in their mouth. They have no fear. They sometimes don't know they're in a dangerous situation. They respond differently to chemical and radiation exposure. And their age and developmental stage not only affects their injury and disease patterns, but also many other things, for example, communication. And I'm not going to go over all of these things, but just to remind you how different children are. So they have higher respiratory rates, they have thinner skin, they have higher metabolic rates, immature immune system. So especially if you have something like a chemical exposure or an injury, they're going to react and have different outcomes compared to an adult based on all of these different physiologic responses. So just some general challenges in pediatric versus adult care. We've already talked about the weight. That leads to a lot of equipment and medication challenges. Often children cannot give you a history. And children usually come in one of two ways. They come in a family package with 1 to 4, usually very upset, emotional parents, caregivers, grandparents, or they show up with no family because maybe it was an infant death at home and law enforcement has detained the family at home, or maybe the entire family was injured. So it's really difficult in both settings, but it's especially difficult if you have no family with you to give you the history or information about the child. And this is just a good time to remember, never assume. It's very easy for me to walk into a room in the emergency department or for EMS to walk up to a scene and just assume the adult standing there is a parent. And in this day and age, that is often not true. We have a significant percentage of children in Florida in foster care. One of their parents may be incarcerated or have a substance abuse problem. We have human trafficking. So one thing I teach, and I learned this from Dr. Peter Antebi, is if I go in, I go, hey, I'm Dr. Hendry, and you are Johnny's mother, and this is, your grandson, your child, your foster child. And that's just a good way to kind of start out and try to determine in a nice way what the relationship is. A little bit of epidemiology. Only about 7 to 8% of pediatric related ED patients arrive via EMS. So very different from adults, where our rescue systems are bringing in adults in much larger numbers. Also, EMS transports less than 10% of pediatric patients, and they're usually infants in that first year of life or they're adolescents. So this means they infrequently perform critical procedures. And this is even in children's hospitals. There are very few critically ill and injured children and very few critical procedures. And I have a couple of studies that I'll show you. If we look at EMS, the national literature shows us that about 80% of EMS agencies in the US see less than 8 children per month. So you can imagine when they do have that critically ill or injured child, it's very emotional for them, and it's very stressful. In addition to not doing many pediatric procedures, they also only give medication about 20% of the time, and that's usually something like albuterol for asthma. If you look at emergency departments, there's some really important numbers here to know. So nationally, about 27% of all the ED visits are pediatric related. It's a little different if you have a children's hospital right next to an adult hospital. But less than 1% of that volume is a true resuscitation. Whereas like where I work, they have adult resuscitations every day, multiple resuscitations. Another big difference with children is they often arrive by private car or walk-in. In my career, I've had a parent walk in the door hysterical with their child shot in the head, walk in screaming, holding a child, have no idea what happened, to find out they fell out of the car and were accidentally run over. Had mothers walk in with children not breathing and not notify anyone. Had a father run down the I-95 ramp with his child. So sometimes it's just a natural response. They think they can get them there faster than waiting for EMS, whereas adult can't transport themselves. So we've seen the same thing in disaster MCI examples, where they don't always wait for EMS. They get in a car and have someone drop them off. So very important to have a way to watch that front door and watch the waiting room. Most important, probably, statistic in this entire presentation is that the majority of children and adolescents do not get their emergency care in a children's hospital or a pediatric specific ED. They go to non-pediatric facilities. And those that are cared for in EDs, they were seeing less than 15 pediatric patients per day, and that's down to 10 per day. And I'll go over the reason for that. So I'm not going to go over these studies, but this is just showing you this is one of the largest children's hospitals in the world. They see 90,000 kids a year, but most of their faculty did not perform a single critical procedure. And even their residents and fellows did not perform many critical procedures. And this study was done before we had some newer airway adjuncts, so it would be even lower now. Again, another study showing that it's very difficult to maintain critical pediatric skills. So we have to have simulation and other ways of doing that. So as I mentioned, most parents take their children for emergency care to their closest ED. And we know that our freestanding EDs are dramatically increasing. So what that is doing is decreasing the volume of children that are being seen at the motherships or per ED. So that's why you're seeing that most of the general EDs are only seeing about 10 children per day. This is a map that a map that I have DOH make for me every year. It's my favorite map, and you'll see the plus signs or trauma centers in the urban areas here. You won't even see all the plus signs. Dark purple circles are hospital EDs, light purple or pink circles are standalone EDs. So in Florida, we're lucky. We have 17 children's hospitals, probably have about 30 specific pediatric EDs. But look at these areas here. We have counties like Glades County, not even a hospital, not even an ED. And then Ken was mentioning early, our state is big. It's 6 hours, across here, 6 hours north to south. And so there's also a big gap from Jacksonville to Tallahassee. So what does that mean for the care of children? So those gaps relate to Florida's rural counties. And because we're the third most populous state, we don't think of Florida as really having rural areas. And if you worked in an urban academic center your entire career, it's very hard to understand the challenges that they're undergoing. Another trend that's happening that is just stirring the water and kind of creating the perfect storm is that many hospitals are getting out of the pediatric business. And over the last decade, about 1,000 pediatric inpatient units have closed in the US. And the same is happening for OB, and the same thing is happening in Florida. So this study came out in 2020, so it's pre-COVID, and it looked at transfers of children to definitive pediatric care for 8 years. And they found transfers had increased by 27%. And I would tell you that this was pre-COVID, pre-explosion of freestanding EDs, pre-mental health pandemic. And so this means that our EMS system is really stretched because someone has to come get these children and transport them. It's the same for adults, but it's not everyone is comfortable transporting a child. So the number of interfacility transports has skyrocketed, but we don't have the means to meet that. Okay, so bottom line is the children are coming. They're coming to all EDs across America, and it's probably going to take time to get them transferred to definitive care. And as I mentioned, hospitals are closing, and there's some real challenges in the EMS system. So with that as a background, I want to tell you what we have been doing and some resources and some programs that are working to improve this. The EMSC Innovation Improvement Center has some great resources. They have a quarterly newsletter that is full of information. They have all types of educational kits. and many other resources. And I'm going to show you some of those. So the National Pediatric Readiness Project is focused on emergency departments. Excuse me one moment. So this started in 2012, and it was realized, to improve, we have to have an analysis, right? We have to do a gap analysis, or how do we know what to improve on? So the first survey started in 2018. The goal was to have it every 5 years, but because of COVID, it was paused to 2021. It is long. It is 81 questions, and no one likes to do a survey. After you complete the survey, and really there's physician and nursing questions, you get a gap report. And there's been a lot of focus on these scores in the media lately, which is why I want you to know about this. Anyone can take the assessment, and I recommend that our emergency departments take it once a year and see what they need to work on. And it'll probably be happening again in 2026. A couple of years ago, the American College of Surgeons said, hey, we want to be part of this, because believe it or not, I mean, some states have even level 3 and 4 trauma centers. In Florida, we have, level 1, level 2, and pediatric. And so even, some of the level 2 centers were not prepared for children. And in a mass casualty event, or someone just happens to walk in the door that was shot or fell through a glass coffee table, they need to be prepared. So it's a requirement now in their verification review. No one needs to create the wheel. They have a ton of great information. There's a checklist that emergency departments can use to go through, and a policy statement. So if someone's kind of starting from scratch, they also have a great toolkit that covers these different domains. So the EIC website is just full of great information. So it usually takes about a year after the survey to get our results. So on one side, you're going to see the Florida results, on the other side, the national results, and you get a score out of 100. So you can see Florida had a score of 75, median 76, so a little bit higher than the national median. We did have a low response rate, and this was with me begging and pleading, because this was still on the end of COVID and people were burned out. And not surprising, those EDs that see more than 10,000 pediatric patients a year have much higher readiness scores. There are pages of analyses where they look, are you green? Are you good? Are you yellow? You got a little trouble, you're red, you're really bad. So I just took one page out comparing Florida to national, and you can see for disaster planning, bereavement counseling, there's, we have some work to do. And this is all available on our website. So with these scores, you're put in quartiles, and I'm going to show you how the mortality relates to that. So if you look at mortality rate, first quartile, 11%. So just getting up even in that second quartile, the mortality rate really decreases. And we're certainly not expecting all EDs to have a very high score. There have been several publications with this data, and it's found that 30% of children live more than 30 minutes from a high readiness ED. Now, this is nationally, not Florida. And 27% of children transported by ambulance do not have a high readiness ED even available. And this is even more pronounced in a rural setting. This is another article. I mentioned to you the PECs, the Pediatric Emergency Care Coordinators, or champions. So the hospitals that had a physician and a nurse PEC had much higher readiness scores, or even just having one PEC really increased their score. So let's switch now to the pre-hospital readiness project. And they have the same thing. They have a checklist that goes over what EMS agencies are recommended to have. Now they obviously have to follow Florida statute, and in EMS, everything is under medical director protocols and medical director direction. And then they also have a toolkit and a suggested equipment and supply list. So we are about to start our first assessment to look at gaps in pre-hospital pediatric care. And this will be done in all states. It'll be starting in May and ending in July. And these are the focus areas that we'll have with that survey. The survey is going to be long, so it's going to take some begging and pleading to get it done. So the newest program that was added to the EMS for Children program is a pediatric pandemic network and a real focus on disaster planning. And this program is really focused more on making sure our children's hospitals are prepared, because what was found is general hospitals were actually better prepared for disasters, doing disaster drills, than the children's hospitals were. So again, it is focused on the children's hospitals, but working with the community. And they have different centers of excellence. The Gulf 7 network, which obviously would include Florida, was the last network to come on board. And these networks are just kind of getting organized and started. And this is just a map showing you there's RAPM in the west, and then there's Region 5 for kids up here, and then the Gulf 7 network. So these are some of the things they're working on. They have different domains, but they're working with everything, trauma, burns, chemical, looking at surge capacity, how we do training. What do we do with our health information, when the hospital's flooded or when there's no power? How do we reunify families after a disaster? What are some of the supply chain issues? And then just comparing the two, what I work on is hospital and EMS pediatric disaster preparedness for everyone in the state, whereas PPN is more focused on children's hospitals, but we obviously have to work together. If you do have an interest in disaster planning, you're involved in that in your institution, there are some great resources that the network has out now. They have hospital surge capacity. So when we had the triple-demic where all the kids had flu, COVID, or RSV, the hospitals were seeing huge boarding crises, similar to what we see every day in our emergency departments for adults. But that was a little bit of a new experience for them. And they're also holding a lot of mental health patients. So there's a surge playbook, and they've developed a pediatric preparedness for healthcare professionals course. It's a 2-day course. It's similar to what Texas A&M was doing in the past. And there's going to be one in Florida in August. There's one in Atlanta in May. So this will be a new course. And I'm looking forward to taking it. A lot of emphasis with CDC, with FEMA, with everyone. There's just tons of disaster resources out there. So big focus on that. There's a new podcast called Ready, Prep, Go. And Florida, myself and Nikki Shimko, who is a transport nurse who's very involved in the evacuation of Golisano Children's, will be featured in an upcoming episode. And then this is a kit that many of our healthcare coalitions have purchased. We purchased one for Florida that has all different types of disaster scenarios, from tornadoes, school shootings, you name it. I think there's like 14 different scenarios. So you might think, well, gee, you told us about all these problems, but it sounds like you got it covered, right? You got all these great programs, everything's great. Not. So October 1st, while we were all meeting, or our state EMS meetings, we knew this was coming. The Wall Street Journal kind of dropped this bombshell article indicating that children are being killed across the United States in emergency rooms. And that's like fingernails on a chalkboard for me, because we're emergency departments, not a room. And they gave us this wonderful map where families could figure out where to take their children. And if you look at Florida, interesting, we have 17 children's hospitals and tons of pediatric EDs and trauma centers, but we don't have many blue dots for where you could take your child. But look at Tennessee, they have tons. That's because Tennessee has legislation that all hospitals must be ranked at a certain level, similar to what we do for trauma centers, stroke centers, STEMI centers. So all they did on this map are list the verified trauma centers. So the map is very misleading. So it was really, they had parents calling, trying to figure out what hospital to take their children to. So this has stirred up a lot, including in our legislature, and many states are trying to introduce legislation to require emergency departments and hospital to have certain things to be prepared for children. So there were some good things that were pointed out, but there were also some misleading statements in the article, but they were not willing to retract any of the things they said. There's also something called the Our Baby Foundation that was started by parents who lost a child in a emergency type setting that did not receive the best of care. And you can see they're focusing on the same thing, breaking the silence. US EMS system is failing our kids. This organization does some great things. They provide simulation and training and resources, so they've turned their grief into action. They also helped develop this app called Find ER Now. And if you go to it, you can, find the closest ERs to where you are. And, do they have a trauma center? Do they have a pediatric ED? Not completely up to date when I looked at some of the Florida hospitals, but it's a start. So because of that article, a lot of pressure has been put on the EMS for Children program. So they're really trying to do better messaging and really showing how you decrease mortality and save children's lives if you have pediatric readiness. Briefly talk about some things Florida EMSC is doing. This is just kind of a one-pager about us. If you want to share information, this is all on our website. We have an advisory committee. These are the appointed positions that are appointed by the Surgeon General. We also have a family advocacy representative. We have liaisons from rural health, from trauma, disaster, child death review, mental health. And then this is our program staff. And Caitlin Pearl, who's my awesome program manager, and Dr. Curtis Gonzalez, I think, are also on the call today. And we work very closely. I'm not sure if you're aware of this, but our Bureau of EMS has regional coordinators, and they go do the site visits for all of the different agencies. So we work very closely with them, and they're kind of our eyes and ears about what's really going on, what challenges the agencies have, or what great things they are doing. We have a website. You can just Google FL EMSC or UF EMSC, and it'll come up, and it has all of our advisory meeting materials, the minutes, the presentations. It's full of resources, and everything I've showed you here today is probably on the website. And we have social media if you want to check us out on Facebook or Instagram. We also have a quarterly newsletter. So if you would like to be added to our listserv to let you know about information or resources or courses, this is our group email, pedready@jax.ufl.edu. We have numerous free resources, and I'll go over these really quickly. If you're not familiar, START and Jumpstart are algorithms we use for triaging patients in a mass casualty event. Jumpstart is modified for pediatrics. It's actually started by a pediatric emergency physician from the Miami area. So we worked with her, and it's just a two-sided badge buddy, by far our most popular product. And we've probably given out over 10,000 of these to different EMS, EDs, professional schools, etc. Have our pediatric ABCs and more resource, which is everything you need to resuscitate a child. We developed this at the request of emergency departments. It can be a magnet, refrigerator magnet, or printed, and it has, based on weight and age, doses for acetaminophen and ibuprofen for pain and fever. We have communication cards that are also very popular and being adapted at a national level. It goes through different emojis to explain what's going on with the patient or tell them what tests are being done. And we have it in Spanish, English, and Haitian Creole English, since Creole is the third most common language in Florida. So these can be used for distraction. They can be used for nonverbal children and adults, and non-English speaking families and children. We also are promoting medical ID bracelets. We work with a company called Sticky J because they have these cute little bands that children like. So you could use it for identification, a child with diabetes, maybe someone that has an allergy. And we negotiate a 20% discount if you're doing it through our website. We mentioned PEC. So what does a PEC do? So a pre-hospital PEC, they make sure that their policies include pediatrics, that they have annual pediatric training, they participate in pediatric prevention programs. So these are just some of the examples of what a PEC would do in a pre-hospital setting, and then what a PEC would do in an ED setting, including making sure the hospital disaster plan includes children. And then we have a resource bag full of educational items, and we're going to be giving those to all EMS agencies that complete the survey as a little carrot. We are working on starting a voluntary ED and EMS program. We're focusing on the EMS program because there was legislation for emergency departments. It did not pass this session. I think it'll probably come up again next year. So we focused on EMS. Rather than call it basic and advanced, we're calling it silver and gold. So we're working on an application. They'll have these logos they can put on their ambulances if they meet the criteria. And this is just an example of and this is still very much a draft form of what the silver level would be. They have a PEC, they have equipment, they know how to use it, they know where to find it, they participate in disaster exercises that include children, they have pediatric policies, pediatric quality improvement, and they do community outreach. And again, the ED one, I'm going to just skip over this. We're just starting, and there's a national process going on now to determine what are the minimum standards that all state programs should have. So that is also ongoing. This is the Disaster in Seconds kit I mentioned to you earlier. We're also doing training with it. We just did our first one in November and simulated a mass shooting event. In the interest of time, I'm going to skip over that. So we work very closely with our agencies and our healthcare coalitions. One of these are just some different photos, and we encourage everyone to send in their pictures to us with permission. No one gets up in the morning and wants to provide inadequate care to children. All of these healthcare professionals, the kids scare them, but they want to do their best. So one of the issues that came up in Hurricane Ian is everyone wanted to help them evacuate, but they didn't have pediatric restraint devices. So we worked with the healthcare coalitions to get FEMA funding and HRSA funding so they could have these little devices to restrain children. And so that was a real win, and that was across the state. So I'll end by asking you, what will your legacy be to help make Florida pediatric ready? And just some considerations are education, outreach, compassion, share resources. We are in a state with a lot of different, very powerful healthcare systems. So as Ken was mentioning, the collaboration with UF and University of Miami, it's the same thing in emergency care. Our children, our parents, they don't care who you work for. They just want you to take care of them. If you're in academia or a large tertiary center, try to think about what it's like to be in the other person's shoes. Maybe you're that rural emergency department doctor with 2 nurses, a waiting room full of patients, and you have that one pediatric crashing kid that you've had in months, and you're waiting 45 minutes to get them transported. And then the biggest thing I hear from EDs, EMS, our flight crews, is they want feedback, they want outcomes. And we know there's HIPAA. However, it's an emotional thing for them. They go pick up some child, pull some child out from underneath a car with their head bashed in, and then they want to find out, did they do the right thing? Did they do a good job? What was that child's outcome? So that's a challenge we're working on. Future challenges include we're having extreme emergency care workforce shortages and burnout. We're having this incredible burden placed on emergency departments. caring for children with mental health disorder, holding them for days while they're awaiting placement. So this would be children that are Baker acted. We're seeing dramatic increases in medically complex children and the autism rates. And then if that's not enough, the latest thing are maternity care deserts. So we're seeing, because some of the OB units are closing, we're seeing women not going for prenatal care. We're seeing increases in newborn deliveries at home or in the field or in the ED. I had one shift a few weeks ago where I had 2 deliveries, and one in the home and one in the ED. And we're continuing to see our rising rates of abuse, violence, and infant mortality. So we have a lot of work to do, but I'm confident that all of you can help us improve care in Florida for children. And I hope you learned something new today. I'm not sure if you did or not, but I want to thank you for the opportunity to speak and open it up for questions. And thank you all for attending.
Thank you so much, Dr. Hendry. Yes, as a matter of fact, I know others learned a lot, and that's not even my first rodeo. While others are putting questions in the Q&A, I wanted to make a number of remarks after thanking you. One of which is, I assume you know my colleague and friend, Dr. Abdul Memon, here in Miami. He's been working with emergency preparedness for many, many years, and I'm going to hit in chat a link to the 14th annual symposium of the Emergency Preparedness Coalition, Miami-Dade County. It's April 9th and 11th. I put the program there. I assume they're your colleagues. You also inspire me, Phyllis, I see in this room now are representatives from Holtz Children's Hospital, Nicholas Children's Hospital, and Joe DiMaggio Children's Hospital of Southeast Florida. We have a regular collaboration among pediatric hospitals here. And I know the leaders there are one, join me in having learned a lot, but 2, give you an example of how sometimes, despite the fact that we think competition is wonderful, we always accomplish a lot more when we cooperate and we collaborate. Let's see, there are questions in the Q&A for you here. Thank you, outstanding. Let me ask you, I have a question. I mean, given your work, I reckon a whole lot of your work includes time that you spend identifying resources to do your work. The idea that a rural county would not have the proper equipment because of budget cuts leaves me thinking, no one wants to, you wouldn't want big government saving too many babies, would you? What is that about in the state of Florida when it comes to resource allocation that you need? What's the problem, and what can we do to help?
That's a big question. I think I'm a big believer in stories. So just like the senator I told you about, when it hits home, when someone has a case and they can bring that to their city council or whoever is funding, that makes a big difference. I don't have all the answers, but I think the big thing is getting someone passionate about it. So the other thing I spend a lot of my time doing is just building relationships. I mean, my family laughs when we're driving through Florida. Oh, we're going through whatever county. I know the rescue chief. Yeah. I know the medical director. I know somebody that works in the ER there. They're like, Mom, do you know everybody? I mean, I know more people across the state because of this work, than I do in Jacksonville. But that's why the PEC is so important. If you get one passionate person that's pushing the button for children, that's where you make a difference and get resources. And if you look at the organization, Our Baby, I mean, another thing are caregivers, parents. If someone can turn their grief or their bad experience into advocacy, that also makes a big difference. And sometimes it's just, they don't use the equipment very often. I mean, this happens where I work. You have something that you don't use very often, and then suddenly, boom, oops, we have this rare event. We need this. Where is that equipment? And so that's why a lot of the focus is on you. And you have to do a check every day. You have to be ready every day because you don't know what's going to happen. So I do think we're making progress. And I am also spending my time, writing other grants, trying to get other resources because Florida is so big and we get this small amount of funds to do our work. So that's kind of what I do. And my other job is write grants and look for funding. So that's kind of, now that the program's under UF, I'm going to be able to do that a a little more.
One of the things that I thought was clear, it's an ethics conference, and yet your talk was one of the best examples I've seen in a while of applied ethics. When you talk about commitment to a vulnerable population, the language that you all use in EMS is going to be slightly different, but the values that you're signaling are values that I think we are shared values, and that are great utility to clinicians in managing really difficult cases, especially sometimes when resources are scarce. Which is why the collaboration the collaborations that you fostered and are managing are really so important. I say we're real familiar with this here. Dr. Memon and his colleagues have done a great job in Southeast Florida, but the population in Miami-Dade County is different than what Gilchrist.
Right.
And the children there are no less entitled to high quality care than they are at any of our great children's hospitals. We just somehow need to be able to find the wherewithal to do so. Hope that's
And
not
that's
woke or anything to say that, is it?
That's why outreach is so important. If the urban hospital, the children's hospitals, trauma centers can do outreach to their counties that refer to them, that's really what's very important. I grew up in a rural area in Louisiana. I moved to Jacksonville in 1989, but probably 5 or 6 years ago, I started being a pediatric medical director for Trauma One Flight Services, and they have a base in Lake City, and so they get that whole stretch of rural counties between Tallahassee and Jacksonville. And I'll tell you, just reading their chart, seeing what they're encountering, the desperateness of people, calling a helicopter to come to a primary care office, calling a helicopter to, after a hurricane when no one can get to a newborn baby stuck in a house, and, people crawling over limbs and handing this, floppy cold baby to a helicopter to fly like crazy, to get to a newborn unit. It was a real eye opener for me about what it's like when you're not right there 5 or 10 minutes away from care.
Thank you so very much.
Thank you.
Phyllis, it means a lot that you've done this. I'm really quite grateful. And on behalf of the Florida Bioethics Network, which, by the way, and by way of continuing an introduction, we are in our 4th decade. It's been an organization of health professionals and other interested parties who understand the important role of ethics in professional practice. And as I mentioned earlier, we've spent a lot of time even before COVID, addressing issues in emergency preparedness. And to learn about your work is really important, and I am grateful. Thank you so very much.
Thank you.
We shall move along with thanks to Dr. Hendry. In response to one of the questions that was put, we're going to ask all the speakers if they were willing to share their slides, and we will, if they agree, put them on the FBN website next week. So please look out for that. It is my great pleasure now to introduce our next session. I think some people think that it just wouldn't be a good ethics conference if we didn't talk about life and death. And something has been occurring in many of our hospitals that I think raises fundamental and really interesting questions about the very definition of death. And so it's a real privilege to be able to introduce our next 2 speakers. I think there are some of them known to you. Laurel Clark, for example. Dr. Clark has been bioethicist at Cleveland Clinic, Florida. Laurel, for how long? It's been a while now.
Years.
Okay. And her partner here, Dr. Kathy Lively, a lawyer and a doctor of bioethics. Kathy and I have been co-conspiring on a number of projects, and hence her affiliation. What Kathy and Laurel have been working on is a project that, even if your hospital does not do organ transplantations, is related to the organ procurement system and network. By the way, I'm an organ donor. I assume everyone else is. If you're not, what's the problem? But we still don't have enough organs. And what Kathy and Laurel are going to walk us through is a new way of a new attempt to try and acquire more organs, which it turns out to be ethically really quite interesting. On that note, Doctors Lively and Clark, the floor is yours. Thank you. And Kathy, you are muted.
Thank you. We're so glad to be here today to present this very interesting and compelling topic. And as I get my shared screen to go. There we go, so you can see now. All right, I've had the opportunity, this has been so informative to work with Dr. Clark and myself have worked back and forth on this. And we're here today, and the topic is the reanimation after circulatory death, the new opportunities for ethical and legal challenges for organ procurement. I'll start off with everything I state today as my own opinion gained from the literature review and the research. I have no financial interest and no conflict.
Likewise, I have no conflict of interest. My views are my own, and I'm very happy to present this new innovation in organ donation. New opportunities often come with ethical, legal challenges, and so we're hoping to put out proponent views, critic views. But let's begin with the context. We're talking about organ donation in the context of donation after circulatory death. So this is growing in popularity. More and more deaths in the US are using DCD for organ donation versus the death by neurological criteria, that is brain death. So that's the context. All patients that would ever have NRP would, normothermic regional perfusion, which I'll call NRP, they'll be DCD patients, okay? What is NRP? So this is where the decedent's oxygenated blood after they've been declared dead is pumped through thoracic and abdominal organs. In doing so, circulation and cardiac function is restored. This allows time for evaluation of organs in situ, in the chest cavity and in the abdomen prior to transplantation and procurement. And there are two approaches, abdominal and thoracic. This just shows the first one, abdominal, and the use of ECMO to pump the blood and perfuse organs in the abdominal region versus the thoracic area.
And when we're looking at this, there's the distinction, and we wanted to point that out, that in NRP, first, the decision is made to withdraw life support. Typically, the patient that we're looking at is going to have someone who suffered a catastrophic brain injury, but is not at the point to meet the neurological criteria of brain death. So after a decision has been made to withdraw life support, the discussion goes to the issue of potential donation. Once those two separate decisions have been made, it begins with the process of withdrawing from life support. There's a period, the hands-off period. The hands-off period is essentially a period of time to ensure that the patient does not auto-resuscitate, that is, begin breathing on their own. In the United States, the standard is a 5-minute period of time. After that, the process begins for donation with cannulation and connection either to ECMO or bypass for the purpose of restoring and allowing the organs to reperfuse and to rest, using the donor's own warm blood. Now, and the highlighted on the corner of the upper right corner is one of the areas where there is a significant difference and an area that brings controversy. In order to prevent blood flow to the brain and to exclude, there's going to be either a clamping, a ligation, or an occlusion. That's one area that brings to a controversy in the ethical debate. Another is that to understand that the cardiac function resumes. The heart does start rebeating. After a period, and the literature reflects a period between 60 to 90 minutes, sometimes a little bit less. After arrest and reperfusion, the donor is then weaned from ECMO or bypass to further assess function. Once it is determined that the organ, and looking here at the heart, is acceptable for transplantation, at that point, the organ will be removed transplanted either directly to the recipient or placed in cold storage or perfusion through ex vivo. And not surprisingly, with any new advancement, there's going to be the two perspectives and the ethical debate. And that's what Dr. Clark and I will now discuss.
So proponents are going to focus on quantity and quality of organs. This is going to allow us to actually procure more hearts and lungs than normally is able to be done in the DCD donor. It's also going to improve the quality of organs. With DCD, it's also called rapid recovery because in an effort to reduce ischemia time, the procurement team goes in very quickly to mobilize those organs in order to get them on a back table in the OR to reperfuse with solutions and preserve them. So this allows that in situ reperfusion and is going to improve quality and quantity of organs. All in a bigger picture, it'll maximize organ donation and allow the donor's wishes and family willingness to donate to be honored.
And the critics, the primary focus and the majority of the critics' opinion is that NRP is going to violate the dead donor rule. We're going to get into that, but the dead donor rule, as well as conflict with the Uniform Declaration of Death. Essentially, the argument is that when the circulation in the heart is reanimated and reversed, that the threshold of irreversible cessation of the circulatory function has not been met, that restoring circulation essentially is going to retroactively negate the former declaration of death. And this brings to the ethical challenges. One of the primary issues, as in both sides, is considering the ethical and the legal questions regarding compliance with the dead donor rule, DDR, definition of death. And in making the arguments, we're going to discuss two commentators invoke various ethical frameworks, principalism, utilitarianism, double effect, and Kant's second categorical imperative.
Okay, so let's begin with autonomy, respect for persons. Proponents are going to say that this NRP respects patients' autonomy. It fulfills their desire to donate and to altruistically help somebody else. It ensures their organs' quality for donation. The controversial preventing of blood flow to the brain only respects the donor's goals and wish to be a donor.
And the critics do recognize and respect autonomy. However, it is noted that autonomy it's not a super factor. It's not going to supersede the other ethical and legal considerations. Consider for a moment, autonomy does not mean that a patient can demand a contraindicated medical intervention. They cannot demand that the medical team take an action that would violate a law. And one of the critics' arguments is it would not override the DDR. But a more concentrated point is that respecting autonomy requires transparency and fully informed decision-making.
Basically, both sides of the argument do acknowledge the need for transparency and informed consent, but there's not agreement on a standard regarding how much detail to provide. Proponents will say that there's no need for a special or specific consent for NRP, and that a broad description is appropriate, and that any further details would be more appropriate if family driven. So if family asks for more information would be given to explain the procedure. Proponents also do not feel that the families need to know about the risk of brain flow. Again, there's burden in information, and so we want to avoid that and avoid any harms of non-donation.
And the critics overwhelmingly argue that non-disclosure undermines informed consent and informed decision-making. And for example, the potential donor, but it's going to be more applicable post-transplant, the recipient, important to remember, and the donor's family may be unaware of the actual procedures involved. That is the restoration of circulation, the risk of blood flow to the brain, and the occlusion. These factors and the questions as to whether or not there's certainty of death before procurement and transplantation may violate moral values, religious beliefs, and concerns. And the question arises, what will happen if post-transplant a family member learns of the details of NRP? An example I would point to in November, right before Thanksgiving, November 22nd, 2023, New York Times article by Joshua Goldstein of When Does Life Stop? A New Way of Harvesting Organs That Divides Doctors. So it's an important factor to consider, and one of the concerns, will that cause distress to the donor family, the recipient, and to the public, risking that it may increase public mistrust and decrease donations? And when we're looking at it, the Organ Procurement and Transplantation Network Ethic Committee, OPTN, in September of 2023, issued a white paper and made the suggestion that in the interest of public trust, respect for persons, transparency, that the authorizations should include the disclosure of recirculation through the heart and the potential for restoration of cerebral perfusion, to consider meaningful differences between NRP and other standard donation protocols.
Okay, so next let's look at beneficence and non-maleficence. Proponents for beneficence are going to point out the positive recipient outcomes, and also, again, organ quality and quantity. Donation, we know, can bring meaning making to families at a most tragic time where there's been trauma, and provide patient legacy. Non-maleficence, we need to be cognizant of, and it is a primary ethical concern to do no harm to the donor. And in that sense, we need to remember that this is a procedure that is done on a decedent. The patient has already passed. The occlusion of blood flow aligns with just the assurance that that patient is insentient, and also to provide a regional circuit of circulation, again, to benefit the perfusion to the organs that are being targeted for transplantation.
And the critics, in looking at beneficence in the context of organ donation, beneficence are really looking more at the recipient. So the proponent's argument is focused on the recipient as to beneficence. However, for non-maleficence and to prevent harm, do no harm to the patient, again, looking at whether or not the donor, because of recirculation, the potential for recirculation to the brain, may experience pain and suffering, because it's unknown at this time as to the amount of blood that may flow through, even with the occlusion ligation. Concerns as to collateral blood flow secondary to anatomical variations or technical failures. So here it is the concern as to the potential for harm and violating non-maleficence.
Let's look at justice.
And this is one where the critics make an argument. This is primarily noted by the American College of Physicians in 2021 in their paper, making the argument that the use of NRP may risk a disproportionate impact onto a stigmatized population affected by the opioid epidemic, with the argument that DCD is more common in overdose death compared to other donors. And in my review of the literature, I would acknowledge this is probably one of their weaker arguments by the critics. However, I would argue that it would be imperative to consider from a distributive justice point as to whether or not there was a disproportionate impact on a stigmatized population with a better burden to the non-stigmatized.
So proponents will be quick to point out the undue burdens on certain population is really lacking evidence. And a concern with justice is withholding advanced procedures will only impact recipient outcomes and perpetuate norm disparities in organ allocation.
And another argument made, and interestingly by both sides, both proponents and critics, is that as the application of the principle of double effect, this is essentially where in the clinical setting, in the medical environment, where it is known that pursuing a course of action in medical intervention will have a good outcome and a bad outcome. The good and the bad, and balancing when it is ethically permissible to proceed. Typically, this is seen in the administration of analgesics, knowing that it will alleviate significant pain with the foreseen side effect of hastening death.
So proponents will point out that organ viability is a good, a moral good, and that the negative consequence of death is a foreseen, and that the timing, the death of the patient comes with the positive good of organ viability.
And on this, the critics' view, again, the critics focus on the intent and what would be argued as the intended outcome, arguing that the intent of occluding cerebral vessels is not to prevent pain and suffering, and that death is more than a foreseeable side effect, arguing from Entwistle and McIntyre that the intent is to create brain death to avoid violating the DDR, and gives the example that it might be difficult to distinguish between harms that are a foreseen side effect and harms that are so close in that action that they must be intended, hence arguing that NPR violates the principle of double effect. And in application 2 of different ethical frameworks, interestingly, both sides also will argue NPR in the context of Kant's second categorical imperative, always treat people as an end in of themselves, never as a means to an end or as a tool or instrument to get something. And critics, ACP in particular, argues that NPR does violate the categorical imperative and never to use the individual as a means to an end for someone else, and make it more of a deontological argument to the utilitarian that no matter how good those ends, that is, no matter how beneficial it is to obtain the additional organs acknowledged as needed.
So proponents will go ahead to say that no person is treated as a means in NRP. The decedent is no longer a rational person, a rational agent, and the only live or recoverable organs of the decedent, are the good.
And critics come back with recognition of the potential for utility, and that it could be a very meaningful and beneficial if there are more organs available to meet the needs of those in organ failure. However, the utility alone does not make NRP ethical. And Wilkinson and Savulescu argue that there's a need to balance utility against the other important ethical and legal considerations for one potential harm to the donors, and also balance that the potential utility with the multiple ethical and legal uncertainties that exist with NRP at this time. And from the consideration of the greater good, will the use of NRP at this time increase public mistrust of the healthcare system, of the donation system, leading to the result of a decrease in organ donation, making there be even a greater deficit? Also concerns as to the impact on healthcare professionals and the risk of moral distress secondary to feeling compelled to participate in a medical intervention with the multiple legal and ethical uncertainties.
Okay, the dead donor rule.
And the dead donor rule, just to note, this is an ethical principle, very important, fundamental, and one of the fundamental aspects of organ donation. It is embedded in aspects of laws through both death laws, actually into some of the criminal codes, et cetera, but you've got it's embedded, but it's not codified. It's not a law in and of itself. And the DDR was formulated by John Robertson in 1999.
The DDR requires that patients must be declared dead before procurement of vital organs for transplantation, and the act of organ procurement cannot occur before the death of the patient. So proponents will point out that NRP temporarily restores circulation in the thoracic abdominal region, and there are no attempts to resuscitate the decedent. So you can only die once, and so there is no resuscitation. There's only a reduction in ischemic time for the reperfusion, by reperfusion, and reanimation of the heart in order to evaluate that for procurement.
And critics, as previously noted, are going to issue with the fact that that donor has been restored. If the patient is declared dead with the full intent and understanding that circulation is going to be restored for the purpose of and before procurement, that they may not meet the criteria for determining death. It may have been whenever they were determined dead, but that initial declaration of circulatory death was either one, inaccurate, it was erroneous, or it was invalidated when the circulation is restored. Bringing to the next ethical argument as to the impact of interfering with or preventing blood flow to the brain. The potential for the resumption of blood flow to the brain is going to be an issue in the post-mortem restoration of circulation. And this is so important to keep in mind because any brainstem function might negate the declaration of death, particularly when it's not been determined under the neurological criteria. Bringing to the point and the argument by both sides, but the critics' position that the ligating of the blood flow to the brain is ethically controversial.
So proponents will again point out that the cause of death is the underlying disease and injury causing the death. The cerebral ligation comes after the death, and you can only die once. The declaration of brain death is not possible after the patient has already been declared death, and it's a legal definition requiring two physicians to make a clinical and do an apnea test, all of that not possible in the setting of DCD. So the donor trajectory is death with or without cerebral ligation and with or without organ donation. And so it's important to know that organs are no longer necessary for the life of the donor and that procurement is not the cause of the death.
One of the strongest statements that I found in a fairly extensive literature review is from the ACP. And the American College of Physicians has made the statement that NRP is more accurately described as organ retrieval after cardiopulmonary arrest and the induction of brain death. That this is a deliberate act that causes the donor to become brain dead so that they, with the intent that they are still considered dead after restoring circulation with circulatory function and cardiac function, including after the weaning from ECMO, and argued that, and Entwistle, that interrupting the circulation to the brain does not, as argued by some proponents, simply allow for the natural progression and death to take a course, but this is actually medicine intervening to ensure death, raising the question, is the transplant team complicit in the patient's death?
Next, we're going to bring up the and discuss Uniform Declaration of Death Act, UDDA. So in this act, an individual who has sustained either A, irreversible cessation of circulatory and respiratory function, or irreversible cessation of all functions of the entire brain, including the brainstem, is dead. The UDDA does not specify medical criteria for determining death because of the evolution of medical accepted standards. The determination of death must be in accordance with accepted medical standards.
And to clarify, the UDDA is a model law authored by the Uniform Law Commission, and UDDA is not a federal law. In order for the UDDA to become enforceable law or applicable law, each of the states has to adopt and enact as a statute the majority of states have either adopted the UDDA in totality or have enacted a statute reflecting that. Florida statute does reflect the UDDA in section 765.511, subsection 4 and 382.009, subsection 1. 765 is the circulatory respiratory, falling in with a lot of the UDDA in accordance with medical standards, irreversible cessation of respiratory and circulatory function, and then going to the criteria for brain death under 382, when the patient is on life support, ventilator, etc., that their respiratory and circulatory functions artificially maintained, then going to brain death criteria and the entire brain, including the brain stem.
Opponents will respond with circulatory death is permanent, even if reversible. Regional circulation is not resuscitation. Reversibility relates to the function of the organ in the organism as a whole, and cellular activity can no longer contribute to that organism as a whole. The organ cannot function alone within that person, and so the person is dead, even if the organ functions within another person.
And from the critic's view, as to the issue of the organ function in another person, we've got to keep in mind that the critic's view in making the argument is that the organ, particularly, and obviously most notably would be the heart functioning, that the heart is not beating in another person at this point. The heart is beating in the donor after being weaned from ECMO. And that restarting the circulation is what raises the challenges to the legal definition as currently in place. But we have essentially at that point reversed the declared irreversible. We've made the irreversible reversible. This is going to nullify the declaration of death according to circulatory criteria. And what is also noted is a UDDA, as well as the law that I've reviewed, is silent as to whether or not a subsequent act can invalidate the declaration of death. And this brings to a point where another interesting debate within the literature is whether or not intent is a factor in the determination of death based upon irreversibility. And in this, we're talking about the intent as to make the determination. We're not talking about the intent as to whether or not the medical provider acted ethically or within the legal role.
So proponents will respond with absolutely. Donor family intention must be appropriate and informed, and accepted medical procedures standards must be followed. It is the intent behind that decision to do not resuscitate that is essential in the meaning of permanent cessation.
And the critic's first argument is that intent is absent from the legal definition of death or from the legal definition of irreversible cessation as it's currently worded. That the definition of determining death under the UDDA and most statutes is based solely upon the individual's physical condition. That is the cessation of respiratory and circulatory function. It's not based upon anyone's intent, including whether or not it is the intent or lack of intent or attempt to resuscitate, or the intent of the donor to donate their organs. That even if we accept the intent as a consideration, and the intent is to preserve organs and not to resuscitate, you cannot separate that from the biological reality of what happens. The argument would provide that circulation is restored, heartbeat is restored, thus that patient has been effectively resuscitated. And on to that, also one of the other arguments is the donor's wishes. The donor's absolute wish to be a donor is not going to be relevant in the actual determination of death. After we've considered these, we then get into one of the even more fascinating, interesting discussions is the issue of recommendations. And interestingly, a lot of the recommendations may come from the same, we're going to see them on both sides, but one of the recommendations throughout the literature is at this time, at this juncture, that NRP should really only be utilized under a research protocol approved by an institutional review board based on the lack of information I noted, and Dr. Clark and I have discussed the idea of whether or not there is the potential that there will be blood flow to the brain and the determination from there, and that the research protocols should include brain monitoring and a plan to abort if blood-brain flow, that stuff is detected. And a lot of the European protocols do require the monitoring of brain function. And in looking at it, that I'm looking at this from a perspective of in an office, behind a desk, behind a computer, considering ethical issues. Dr. Clark, on the other hand, you're right in the mix of it in the clinical setting. And from that, how do you view it from the clinical side of the proponent as to the reality of using NRP only under a research protocol at this time?
I have to agree that we need data, we need evidence in order to proceed with evidence-based practice. I think this is an expectation in science. And so I do agree that we need to move with protocols, but I see that there are challenges with that. If we're researching organs in a donor, that organ that is under a research protocol would have to be accepted in a recipient that is, agreeable, I think, to accept an organ that's under research. So I think there are some challenges with that, but we do need to proceed. I agree with the American Society of Transplant Surgeons that we need both quality and, or I should say qualitative and quantitative studies to really understand the procedures so that we can move forward and say that we're basing our decisions and our innovations and our procedures moving forward on evidence. As far as brain flow activity, there have been some studies done. The brain flow that was detected in some studies has shown that the intracerebral blood pressure did not change after ligation and then the initiation of the perfusion. And in another study, it showed that the flow wasn't compatible with life or neural activity. But I think to assure public and not disrupt public opinions and cause moral distress, I think it is possibly a procedure that could be done to put that to rest.
And I think we can look at too the amount of activity as to how often NRP, particularly when we get into the thoracic area, is actually being utilized in the United States. Right now, there's only a handful of hospitals, I believe NYU Langone, University of Wisconsin, Vanderbilt, University of California, San Diego. So it's still a fairly limited procedure, used a lot more in Europe. I think in Spain is one of the more predominant areas where there's a lot of NRP. And there's also a lot of the controversial debates. I think too, as Dr. Clark noted, one of the concerns is to the idea if you don't want to see a procedure that we're going so far in medical advancement that we take one step forward and fall 20 steps back. One of the other points that's been brought up, we discussed it a little bit, but even to go more deeper into, is the recommendation, such as from the OPTN and a lot of the commentators, is the absolute need for special informed consent, particularly into the brain reperfusion, the ligation, and the informed consent and decision-making after thoroughly explaining this process, including every step. I think this is another area where we've gone back and forth on. From a legal perspective, I'm going to be, waving it like, absolutely, we need full consent. This cannot happen unless the individuals understand and know what is happening. So when I'm looking at that point, it's easy for me to sit behind the desk and say, yeah, you need full consent. But Laurel, when you're looking at it from the clinical perspective, how do you see this going through with OPTN's recommendation for full-blown, full disclosure, and how that would carry out in a day-to-day practice?
Well, as medical professionals, we do have to practice within the context of law, and informed consent it's part of the law. So I think we do have to give some form of informed consent. But I do, have a lot of caution because of the family burden that might place on the family. They're going through a very difficult, traumatic time, and a lot of it just depends. Some families are very pro donation, and they're like, whatever you got to do. You may have some questions from family members, and they want more details. And I really think I do uphold the need for that to be family driven, even if it is rather explicit, as is recommended by the OPTN in the consent form. Chances are family members in their state of, sometimes a state of shock, are not even going to really realize what that means or even have the wherewithal to ask questions. So I think we really need to go case by case. I think importantly, you had mentioned, Dr. Lively, spiritual and religious concerns. And I think that that pre-transplant huddle between clinical teams and the OPO teams, I think that we have to be very careful with information, that type of information is passed on between the teams. So if there's a possibility that there could be a religious concern, that's addressed at that time, and there's the team is strategizing how to relay and discuss that with the family. I think that would be traumatic if post donation they realized that possibly something in their religious belief was not honored. So I think there's a lot of work to do there. I don't think it's unsurmountable, but a lot of discussions still need to happen to see how we can move forward with this innovation.
And we go back and forth on that, but do we see that there may be the need for a more standardized? This is the standard consent that we have, particularly if we're going to utilize a procedure as controversial as NRP, and that they do need to know that there could be the idea of the restoration of the heart function, particularly understanding that, the individual's removed from ECMO and also to the cerebral perfusion. And we could go back and forth on that for hours. I think we may have, anyways, onto that. But also this goes into the idea of another recommendation that has been made, and the idea of the need for public conversation and education is actually pretty well reflected in both sides of the debate. And even to the point of bringing in forums to determine what is the public perception, because we're looking at two ends. One is protecting the vulnerable donor, the family, but also realistically, we need to protect the organ donation system and the need for the public, both conversation, education, and getting an idea of the community's views as to what should be disclosed. Do you have any comment on that, Dr. Clark?
Well, hospital systems may want to have their community advisory boards part of the decisions, making sure that they understand and get a temperature of how their community feels about the procedure. I think a lot will rely on OPTN, the OPOs coming together and giving guidelines. They have a means of public commenting, and I think that is a great way to proceed. It's kind of already a method that is used, and I think that hospitals are also relying on that information to come through their OPOs, and that there be an agreement at that level. And so I think waiting on that and working with them and collaborating between hospitals and OPAs is going to be, or the OPOs is going to be an imperative for moving forward.
And we also kind of go back and forth on the issue of education and the need for the public to be educated, and particularly with the influence now of, you look back to 1999, whenever the DDR was formulated, rapid forward where we are today with the incredible amount of that is out on social media? And is that really educating the public, or is that a plethora of disinformation? And the other recommendation goes back and forth on both sides as to consideration of revising UDDA to address what is a disconnect between the law of the UDDA and the rapid advances in technology and medical intervention. And if we've seen over and over, the law is like way behind the advances, and whether this needs to be done, both in the context, I think, of the NRP that we're currently discussing, but also as to other advances in medicine, as to whether there does need to be a revisit or rewording of the UDDA. And in this context, it's been noted too, and a very important, that any redefinition of death in the UDDA is clearly not done that would appear to solely benefit transplantation, as that would undermine trust. And in the research noted too, one of the articles recommended that any redefinition of death will require societal and legislative buy-in and should not be top-down decision imposed by the medical community. And that recommendation was actually by 2 MDs. One is a cardiac transplant cardiologist, and the other is a director of a bioethics program, Abed Khan and Bob Klitzman. But they're recommending that the redefinition come from the community, from society. And again, from your clinical, daily working in a clinical environment, do you see that as feasible with the redefinition? Clearly as to the issue of clearly not worded to benefit transplantation, and importantly, interestingly, from the idea of it not being top down.
I think those are great points. I do have concerns. I have to agree with Adam et al. That, changing these rulings and laws could bring about public disruption. And not only that, but could make professional healthcare providers, transplant professionals kind of question, well, we had to make a change, what possibly make them wonder about what we had done in the past. Was that maybe not accurate? But I think that we need to cautiously move forward. And I would hesitate to make any changes, but work within the framework that we have already established. DCD has been, growing in numbers, and I think that we need to stay within that context.
And maybe the Uniform Law, I like to say that one, Uniform Law Commission may actually agree with that. But in 2023, it was in the summer, May, June of 2023, Uniform Law Commission did meet and did consider revisions to UDDA. However, that decision as to any revisions was placed on pause. It's unclear as to how long that pause will last, but it's certainly under consideration and it may be done. Finally, in closing remarks from our proponent, Laura, if you want to go ahead with your closing remarks as to our presentation.
Well, I want to agree that I think there are ethical and legal questions that still need discussion. I like to mirror what Angie Wall from Baylor Institute Transplant says, that organ procurement procedures that improve and advance organ utilization and can lead to better recipient outcomes is ethically acceptable. And I think it's really almost ethically obligatory, because we're already seeing positive outcomes in recipients. And this is going to have a positive impact on organ donation. We work in a supply-demand deficit. Many people are in need of organs. I sit on selection committees and hear many cases every month of people who are waiting for organs. I also want to mention LVAD patients quickly that are connected to a device. It's a challenging state to be in. There's about 4,000 or so in the US. We need to consider that and try to move forward as quickly as possible with providing this good to as many of these patients who are in need.
Thank you. And in my closing, I would mirror the idea that there is an absolute need to find a way to find more organs to meet the needs of those that are on a waiting list. However, I would argue to proceed with caution, particularly with all the questions that remain particularly as to TA, NRP, that we just don't know yet, as to whether or not there is perfusion to the brain, as to whether or not there will be any reanimation of the neurological function that would allow that individual to experience pain. Also considering as to the total impact, and would there be pushback and the paradoxical effect of decreasing organ donation when the public believes of what is happening? Is that person dead at the time that the organs are procured? A lot of it goes back to the debate as to whether or not to use the circulatory criteria versus brain death criterion. But consider for a moment, and we're looking back from the public perspective, that for eons, a beating heart was a determination of life. Does that make a difference if the public hears that the heart is now rebeating? And are we, shooting ourselves in the foot by moving forward that advancement? And in looking at the literature, I would also ask whether or not a lot of the critics are not necessarily 100% opposed to NRP, but is it more of skepticism based on what we currently know in the evidence, hence the need for, and I would argue the need for conducting NRP under a research protocol to follow parameters as approved by the IRB or closely monitored by an ethics committee, and consideration as to whether or not there does need to be an amendment or a revision to the UDDA to reconsider aspects of the determination of death based upon irreversibility, knowing that irreversible may not be so clear any longer because medical advances can make that more difficult to determine as medicine is able to reverse what had just been declared irreversible. So this is an area that is open for a lot of debate. We would very much welcome any questions, comments, and particularly comments as to how do we proceed with the recommendations and where is the feasibility of going forward. And on that, I will end my screen.
Linda, thank you both so very much. That was an exemplar of how to address even-handedly from at least the two sides that are represented a really tricky ethical issue. Thank you both so very much. There are a number of questions that I want to share with you. One of them, you've addressed the so far limited adoption of normothermic regional perfusion at hospitals around the country, around the world. One question is, have any laws been passed explicitly addressing this that you know of?
I am not aware of any, at least, and my research really focused on the United States. I would not go out on the limb to answer as to into the European countries that are currently utilizing NRP. I know that in Canada it had been rejected, but I'm not aware of any laws in the United States specifically addressing the issue.
Thanks. I would, if I were a legislature, I would sure want to have more evidence before I decided what was obligatory or forbidden. Another question, say a little bit more. I think that for some of our participants today, this is well, we're familiar with some of the issues related to organ procurement, if you will, and organ allocation. This is a new topic. Say a little more apropos the question about the distinction between thoracic and abdominal normothermic regional perfusion.
Dr. Clark, I'm handing this right to you.
So abdominal NRP is going to be perfusing intestines, liver, kidney. The thoracic is going higher up into the chest, into the lungs and the heart. So those are the main difference. We have NRP in the abdominal area is being done. It's only in the thoracic because of these ethical and legal concerns.
If you're not in the thorax, you don't need to worry about the heart. And so therefore, there's no need to worry about it restarting. There's no need to clamp any other vessels.
I think that's one of the big key points is that the NRP for the abdominal area only, it's really where things get a lot more dicey and a lot more controversial as when it's going into the thoracic and it's actually reperfusing and cardiac function resumes and the heart starts beating. That's where you see a lot more of the debate.
Dr. Marks has written, I don't know if you can see these, the practicality of obtaining blood flow and or EEG in a patient on ECMO. Pardon me, that'd be extracorporeal membrane oxygenation will be very difficult. The notion of ligating all cerebral antegrade flow prior to the determination of death in conjunction with these technical issues creates an even more confounding technical problem. Additionally, patients' families struggling with end of life care and dealing with the ligation of antegrade flow will be most problematic. Not sure how this could be carried out. Thoughts?
This is why this particular topic is just so difficult and you can go back and forth on it because it is so, there's so many factors to it and we're discussing it. And Laurel, Dr. Clark, I'll let you get into the fact of the concerns as to then and monitoring the neurological activity and bringing a neurologist in, et cetera, how far we go on to that point. And just there's so many unknowns, but Laurel.
I would just refer to Manera et al. 2019 as a common reference. They did a exact study on the collateral blood flow, which showed that the flow rate was less than needed for what would be needed for life. So that, and also the University of New York did 2 cases where the flow study showed absolutely no flow. And then there's Marquise Valdecilla did another study with 2 abdominal NRPs and 2 TA NRPs, and they found that, again, like I said, the intercerebral pressure monitoring was used and the pressures were static. So I think it begs for more evidence. We just have those few cases, but so far I think that at least these initial cases show that it's really minimal and that, you know, we can try to move forward
And I think
under a
too,
research protocol.
important to understand, and I don't think we noted this, but NRP and TA NRP, particularly as in the United States, is so new. And NYU Langone started, and I actually remember whenever it happened, it was in mid-January of 2020. It was the first time that NYU did an actual NRP procedure for a heart. So, you know, we're going very rapidly, considering too that there was kind of that standstill of time from March of 2020 through, you know, for a couple of years because of COVID, but it's such a new procedure being done in the States. And it kind of go back to in Spain, for example, where it's done frequently, keep in mind, but Spain utilizes an opt-out system for organ donation. So there's going to be that different variable. We're in the United States where it's a voluntary system and you opt in versus opt out. So you've got more of some of the more controversial concerns as to impact on donation throughout the public.
Very good, thank you. Another question. By the way, just in the interest of good online hygiene, if you're using your phone to call in, please change your name so that we know who you are. We want to make sure that everybody here is identifiable in one way or another, just to make sure. So thank you for that. Please change your phone number to a name. Next question about informed consent. So someone suggests it'd be prudent to request when it's known that NRP is going to be used. Why not give us? Why not disclose as much as possible about that? Is it really? What's the nature of the anxiety you're concerned about? Is it Is that the right, what would be the best response to that? I guess that'd be something that, well, both of you might have an opinion about. How much consent is necessary for this?
Laura will try to comment.
Well, again, we have to give, if we're giving informed consent, we have to let them know that machine perfusion is going to be used. And I think that, there's probably maybe someone from OPO on the call, who is doing these, informed consent that could even comment better than me. But I think that, the concern is too much information. Too much information is the proponents feel could be burdensome. I think it's really, how you may deliver the information. I have my experience with these, representatives from OPO is, they're very graceful in their conversations and able to judge the family's readiness for certain information, how to broach certain information. And so, again, I think that it should be, told in such a way that it doesn't bring undue burdens, but at the same time avoids any potential future harms. Like Kathy mentioned, if the family finds out at a later time their loved one's heart was reanimated in situ.
And
I think it is an expectation of families. I mean, that's what donation is all about, is that the heart is going to beat again. It's just making sure they understand that it's not going to be, that it is going to be in the chest.
And I think I certainly respect the idea and would agree with the matter of delivery, of how that is delivered, but I have argued, and I'm just a strong proponent of full disclosure, and would argue if I'm going to err on it or an opinion on error, I would err on the side of maybe a little more information than withholding. My concern and the argument would be that withholding the information could be more detrimental. But agree 100%, as Dr. Clark has said, the absolute need for how this information is given to the family.
It seems like some of these are empirical questions too. I mean, pointing to the need for more research. It'd be interesting to find out what people want to know, what happened. You could, any number of studies would be possible, whether whether there's a placebo or not. Sometimes the answer to these questions is going to be provided by more research. Thank you for that. Pardon me. A number of comment, high praise remarks in the Q&A. Can you speak? Who pays for NRP? And if a facility doesn't have ECMO, how do they manage the do they transfer to the donation site? Or the transplant site? Anybody know how that works?
I have not read anything where if it was NRP was being conducted in the facility that they would not have the equipment. And you look at where it's being done in the United States right now, it's major medical centers that would have it. And I did not see anything. Laurel, did you see anything else specifically as to who would pay for NRP as compared to any difference in any of the other protocols? I didn't.
I'm not the best person to answer that, but it is and does fall on the side of the procurement team. So I think it would be equipment that the procurement team would have with them. There has been discussions about transplant centers being developed. There's additional cost with developing a center primarily for procuring organs. But that's also where the cost would fall then. If there's a transplant center where a potential donor patient would go to be withdrawn and for procurement. So I'm sorry, I don't have more information on that, but
It is
I
evolving.
think we went back and forth and looking at the costs, and there's arguments that NRP is more cost effective. I'm looking at the cost of the ex vivo perfusion devices and how expensive they are for the actual equipment, looking at $40,000 to $50,000 per unit. But there wasn't a lot of information out, and neither one of us are involved directly in the finances. But I think suffice to say that anytime when you're looking at organ donation and transplantation, there are significant costs.
I want to read a couple of comments. Well, here's a comment just to acknowledge it from Dr. Aladdin. Amanda Aladdin, by the way, is the chair of the ethics committee for the Holtz Jackson system. She says, fascinating talk, etc. Thank you. I can see this being challenging for families to understand and accept, especially in scenarios where we encourage them not to pursue CPR as it would be ineffective. Very interesting twist. What happens if you got to that point based on the idea that you're old, you're really sick, when your heart stops, it signals a failure of therapy. Therefore, we don't recommend CPR, therefore your DNR, based on the idea that it would be ineffective. This would suggest that in certain circumstances, it might not be ineffective.
And I think that goes to the heart of the ethical issue that essentially it's being determined that ongoing treatment is going to be ineffective, hence the withdrawal and the DNR order, of course. And now it's being told, but by the way, the heart is functioning. I think as to the fact of the age, I did not read anywhere there was a cutoff in age, but particularly you're looking at if you're going to transplant the heart, it may be in a younger person, but again, their catastrophic injury or illness and the determination of they're being withdrawn from life support because they're not going to survive. Death is going to be inevitable at some point, and they're not brain dead. So there's that differentiation. You're basing on the fact that their body is not going to continue, yet we've got the reanimation. Now we've got the beating heart, and that goes exactly to the issue.
Dr. Singer, Glenn Singer, would be the chair of the pulmonologist who chairs the Broward General Medical Center Ethics Committee. Says, why bring up monitoring brain function in NRP? When a clinician monitors a function, it's with the intention of potentially intervening to correct pathology. I'm not intervening in a deceased patient who's being prepared for organ harvesting.
That's a great question. That's a great comment. And I think, it would just be an initial monitoring until we can put to rest some of our concerns for reperfusion of the brain and that patient being sentient and possibly aware. We need to put that to rest.
I think that goes to the key because it's so unknown at this point. And for a determination, if through the research and studies, there was a more definite determination, I think that the concern as to neuromonitoring would probably be lessened.
Also, probably a great question surrounding how you would even know if there had been any, neurologic reanimation. It's a great question. Harriet Washington, excellent balanced presentation. I have concerns about the recommended community notification because it's been deployed in a disastrously ineffective and frankly deceptive manner during some, I don't know what EFIC is, but some research studies. I'd also like to see us abandon the community language in favor of one that recognizes individual concerns. Well, so now we've got a great Kantian utilitarian conflict here. Any thoughts about that?
Laurel?
I think we have a responsibility to both. We have a responsibility to community and to individuals. So a cautious approach can help us do that, I think, as best as possible.
Dr. Weinstein asks, is any entity championing NRP in Florida? I don't think the word is championing. I think many of them are considering it because the surgeons want to have more organs to do more cases, which I think is generally speaking a good thing, right? So not championing. I'm answering your question for you, notice. But any thoughts? Does anybody know how many hospitals in Florida are contemplating this now?
That I don't.
Yeah.
That we're unaware of.
I think certainly at the larger ones, this is on the agenda. It is being proposed, and one of the reasons why this session is so important is that we are trying to educate our colleagues about how to have a discussion about whether any individual institution should do this or not. This is the clear, practical utility of applied ethics in our state. Yes. Dr. Elia Cohen, why not cut to the chase and just remove the client from the vent when the organ is ready for procurement? Not even wait for the heart to stop beating. The point is there appears to be no clear morally relevant distinction between the two scenarios. Therefore, the moral status of NRP appears to be no different than that of simply taking a patient off a vent and harvesting their organs without waiting for circulatory death. Therefore, if we wouldn't do the latter, what justification do we have for the former? A provocative question.
That is, and if you take this further, there's also been discussion in the literature, kind of going that path as to, it was actually Julian Savaleska and Dominic Wilkinson, and one of their articles as to actually going even farther as to euthanasia by organ donation. So, you're getting into the area too, where this is the poster child for the slippery slope too, of where do we go and where do we stop?
Oh, dear. Oh. So they're bouncing around. The questions are pouring in. We have time for just one more. I'm trying to find the best one. Could either Dr. Clark or Lively review for us the pros and cons of saying that, quote, NRP's attempted occlusion of circulation to the brain is not going to cause the death of the patient?
And can you just repeat that, please? You kind of broke up.
Review the pros and cons of the following statement. NRP's attempted occlusion of circulation to the brain is not going to cause the death of the patient.
I think that is certainly that's the proponent's argument, that the occlusion does not, because they're already dead.
Yeah, they're already dead. They've already died by circulatory death.
And the opposing argument is that they haven't, although there was the initial declaration of circulatory death, that it was either inaccurate or it was invalidated. Hence, now they're no longer dead by circulatory criteria. In order to be dead, there will have to be brain death, and the way that is done by the occlusion leading to this brain death.
Thank you. Well, what a fabulous presentation. What the comments here are really telling and accurate. This was wise, it was balanced, and it was thoughtful. And I can't say how much I'm grateful for the two of you for doing such a really good job. Thank you so very, very much.
Thank you for the
What I
opportunity.
miss about not being in the same room is when you get through with a really good presentation like that, we'd be able to applaud. Well, we can applaud, but I mean, once again, the webinar structure is designed to keep a little bit of control over things. We've had a number of, we want to make sure that everybody behaves well, but sometimes when we send these invites and the notices of this conference and the links out, they're widely available. Please, if your number, it begins 1917 or 917, please change your name or log in again so we know who you are. Thank you for that. Kathy, Laurel, thank you so very much.
Thank you. Thanks.
We are, believe it or not, almost done for our last session. And right before it, Ray, I wanted to, well, I'm thanking people. The University of Florida and the University of Miami have for a very long time let us do this. When you're doing stuff for the FBN, you're doing stuff for the FBN, a statewide network, and not therefore for any particular institution. And so a special shout out to the Gators and Canes and their institutions, or our institutions, who allow us to do this, who allow there to be staff support for it, who allow web services for it, who allow all of that. None of it is paid for. It is all for this purpose and the sake of this kind of community engagement, which means that for all the challenges we face in higher education, sometimes things go right. So against that, what we thought we'd have some fun with here, if that's not the right word for it, is for Ray and Ken to talk a little bit about one of the greatest challenges that I think arises most commonly for us at Shands, at Jackson, at UHealth, and therefore I think we can infer safely everywhere. He's been self-effacing, but just for the good and order, Dr. Ray Mosley is indeed the founder of the Florida Bioethics Network. He's the Ethics Service Director for UF Shands Health Center and Associate Professor in the Program of Bioethics Law and Medical Professionalism at the University of Florida College of Medicine. Ray, you got some slides. Why don't you get us started here? Ray and I are going to do a bit of a back and forth about one of the most vexing challenges that we face. Hospitals, large and small, academic and community, all face the challenge of managing incapacity. And Ray has prepared the slides here. And what we're gonna do is go through them and annotate them, comment on them, and try and see if we can't provide some support. Once again, from the directors of very large ethics services at the very largest hospitals in the state of Florida. It's an opportunity, we think, to share some of the experiences that we've had. Ray, the floor is yours.
Thank you, Ken. Just a couple comments. The irony that you're in charge of making sure people behave is kind of striking to me, but I think you're up to the task.
Thanks, Al.
The other thing that I would note, tying the last two excellent sessions together, and maybe this session too, in a sense, is the trying to figure this out is really important for an organization like the FBN because of the state of affairs of the world and of how easy conspiracy theories can arise. So I saw that in the first talk, excellent effort to kind of get a handle on everybody being up to speed and getting metrics for evaluating trauma centers for children and some of the headlines you see there. And so you can imagine the headlines you would see in the press over the second set of issues that we just saw a really good discussion of. And it's really important to have some really good consensus kind of before you take it out on the road and before you spending all your time reacting to that. I'll also note that one of the lessons we learned from COVID is there's a good chunk of people out there that think, in spite of the fact that from my observations of 35 years, physicians really are trying to help people. There's a good chunk of people out in the community who think physicians are in it for the money and trying to profit off of this and have nefarious other reasons to do things. And so we got to be really careful about this, and it's important to have these kinds of discussions and building consensus, at least among the professional community, before we get it too far into the public sphere and don't have nice, clean, clear answers to the questions that will be raised. So kind of leave it at that. One of the topics we want to talk about today is a really common thing around hospitals, and that is how do we address decision-making, recognize the importance of informed consent. How do we address informed consent issues with incapacitated patients? In other words, how do we deal with proxy issues? And this is occupies a fair amount of my time. It occupies a fair amount of every ethics committee in the state. Gets a lot of questions about proxy decision making. So that's the issue that I'd like to talk. Let me get the first slide, Esther. Just a brief overview, kind of as a review of the kinds of things an ethics service does. You'll note that I refer to, I've been doing this for a couple of years. I think Ken and I kind of come to this conclusion. There seems to be a pretty significant difference in a hospital setting between a committee and a service. And a lot of times committees are kind of once a month kinds of things and are not actively engaged in helping, specific cases that come up routinely in a hospital. And that's more along the line of a service. Also, committees have a special kind of a perception from a lot of hospital administrators as something you're supposed to do as kind of your volunteer part of being as a good citizen of a hospital. And a service is something that seems a little more, takes more effort and as opposed to just volunteering. So I would recommend that you think a little bit about in your hospital about identifying your ethics activities as a service as opposed to a committee. So here's a list of the kinds of things that a service does. Most places have some version of a 24/7 consultation availability, at least to triage the case. There's multiple things an ethics service or a committee can do, including identifying problems, recommending optimal solutions, and assisting with implementation of those. I think it's nice to keep those in mind. Sometimes you're asked to do one of those things, but not all of those things. So there's a variety of things a service can be asked. And last but not least is educational programs and forums. Ethics services, ethics committees just aren't successful unless you have a robust educational program in the hospital and for your patient community. I think those are two things that we tend to not put as important as they should be. I know here at Shands, since we've instituted a regular ethics in-house grand rounds and working on different units with educational activities, the number of consults has gone up dramatically. So there's a direct relationship to how well your education does for your staff and the number of consults and the quality of consults. Part of that is just human nature. People don't want to share problems unless they know who they're sharing them with and trusting them. And one of the ways you build trust is being present on units and letting people see who you are and what you do. Let's jump right in. Okay, back up, please, Esther. Let's hear. Sorry, Ken.
Friendly amendment. The point about the ethics service is a really important one. Remember, if you want your hospital to be accredited by the Joint Commission, you've got to have in place some kind of process or mechanism to address these issues. And yet Ray and I, for a very long time, have been encouraging hospitals around the state to provide such a service. Many still do not. Having an ethics service does not consist in having 10 names on a sheet of paper to show to the site visitors. The committee is the most visible thing, but if you can have a robust service in the way Ray described, that committee actually needs to meet. It needs to educate itself. It needs to let people know, as you've just heard, that they're trustworthy colleagues who can help solve practical problems. That we do not, when we do ethics, hold hands in a circle and get in touch with our feelings. Well, that'd be a lot of fun. We should do that more perhaps in the hospital. But we are actually helping our colleagues solve real world difficult challenges. That is a skill set. You would not allow anyone to practice nursing. You wouldn't let me practice nursing because I don't know enough nursing. You wouldn't let Ray do that either. Same with medicine, same with social work, same with the chaplain. See, everybody in all of these services has adequate preparation, adequate education, adequate professional development. And that's been one of the FBN's goals from the beginning, is to support that professional development. The idea of a clinical ethics service is not just Ray's idea. Ray is pointing to a standard that we think is essential for institutions to adopt. Thanks. Next slide.
I would just also point out, Ken, that one of the red flags I see when, I know you see this too, when we're asked to go to another institution, another hospital, and speak with their ethics committee or ethics service, is ask the question, how often do you meet? And the answer that you don't want to hear is whenever needed. And then you ask a follow-up, how often are you needed? And it's maybe once or twice a year. That's a pretty bad sign of a structure for
it's also wrong because they just don't know when they're needed.
That's right.
Right. By the way, ethics, you don't need an operating room or a cyclotron. Surely a modern hospital ought to have budgetary resources to support professional development, to send people to a conference, to be able to support committee activities. If you've got zero budget for your ethics service, then you've sent a loud signal with that.
That's a very important point. So here's a series of cases, and I call these one-line cases. And these are cases that the first line should immediately raise a scenario that you've no doubt experienced multiple times in dealing with incapacitated patients and proxy decision-making. So the first case is the case of a long-lost relative. So routinely, this happens at our institution. I presume it happens at lots of your institutions. You'll have a patient in the hospital that's incapacitated, and you've got some indications of who the relatives are, who the next of kin, and you are trying to figure out how to contact them. And you go down to the list and you can't find people that are pretty close on the list. And you keep going down the list until you find the next person on the list. You call them, and what happens is they say, I don't have a clue what my uncle would want. And we ask them to make decisions for them. So part of the issue is that appropriate or not? So when you go down the proxy list, you get to the other relatives. That means you're past your spouse, you're past with the majority of adult children, you're past the parents, you're past brothers and sisters. You get down to the other on the proxy list, the other relatives. There's a note there in the legislation that says they should know the patient well, have regular contact with the patient, and know the patient's moral views. That's a pretty heavy lift, and we often discover that it's not just the other relatives that we should be asking those questions. Sometimes it's people much higher on the list don't know those answers or spend much time. Especially here in Florida, this is a pretty common phenomena that a couple retires to Florida, one of them dies, one of them has a stroke, and we're calling up the children who do not live in Florida and who have not visited recently. And they don't have a clue what their mother or father would want. And that's a huge lift to have them become proxy decision makers. Oftentimes the answer when we do ask that proxy is they really don't know what they want, do everything is the typical response. And it's not based on anything about the patient's values or anything else. It's based on, I don't know what to do, so just do everything, which of course is not a helpful response.
Well, it also is not a very medically or nursingly apt one. It's worth underscoring, as you know, that in the chapter 765, it refers to surrogates and proxies as legally authorized representatives. That means their first job, based on what you've just said, Ray, about needing to know the patient, what if the patient had capacity would she ask for in this circumstance? And that is also not a license to demand non-beneficial treatment. What's interesting is, and I think this is also a very common phenomenon, people think that if it's somebody reasonably high up on the list, it's a spouse, it's a kid, it's a sibling, it's a parent, that they are decision makers. They're not decision makers, they're conduits. If you don't know what the patient would want, then the best way to decide how to go forward is what's in the patient's best interest. And I think in your experience and that of many of us who do this, a loving child will say, I want this. And the proper response to that is, with all due respect, we're not interested in what you want. We're going to be compassionate. We're going to provide bereavement support. But our job under ethics and the law is for you to communicate with us what the patient would want. And sometimes we get requests, as I know you do, where loving, loyal, grief-ridden, guilt-ridden children will insist on doing all kinds of things, do everything, the phrase we hope never comes from any student or colleague's lips, is not a meaningful bit of advice. It means I just don't want my mom to die, and I'm willing to have you do a bunch of stuff that you believe won't work to try and make me happy. That's not good healthcare.
Let's look at the next case, Esther. So this brings up the point you just made, Ken, the case of I want him to be full resuscitation. And the proxy's job, of course, is to determine what the patient would want, if we could ask them, not what they would want. And here's an interesting phenomenon that I think we fall into. And this is, I call it training. We often inadvertently train proxies to make decisions based on their own personal interests. So take this scenario. You have a patient in the hospital. You thought they were going to get better and eventually leave. That's not happening. It's getting worse, and the patient becomes incapacitated. And so there are patients in the hospital for a week or two, and we're going constantly to the next of kin, the proxy, if you will. We're going to the proxy and we're asking them, can we do this procedure? Sign this consent form. And whole series of things happens daily. And pretty soon the proxy comes to the view of, I'm making the decisions. They're asking me to sign it. They're asking me, what should I do? And so we've now trained the proxy to think it's their decision, not the patient's decision. So, and then what happens when we finally get to a point where we realize the patient's not going to get better, they're kind of in the dying process, it's going downhill, we should consider do not resuscitate, we should consider maybe withdrawing treatment. We go to the proxy and we say, we think it's probably time to accept that they're not going to, mom's not going to get better. We should think about moving to comfort care and think about withdrawing life-sustaining treatment. And the patient says, the proxy says, no, I want you to keep doing everything or keep going with the treatment. And then everybody gets upset about that. And we start trying to convince them to change their mind in various ways. Maybe they just don't understand the situation, etc. And sometimes that drags out. Oftentimes an ethics consult is called. And the first thing you do is start saying, hey, it's not really your decision. You're just supposed to be telling us what the patient would want. The effect of that is that the proxy often gets angry. And the reason they get angry is because they've been told for the previous couple of weeks, it's their decision. Now for the most important decision, we're telling them it's really not your decision. You're just supposed to tell us what daddy would want. And that's a problem. And it takes a while to untrain the proxy and retrain them into the actual role, and that is to make the decision that the patient would want. One of the ways to avoid that is to routinely speak of and document proxies, conversations with proxies in terms of the proxy reports the patient would want this. That's an appropriate documentation as opposed to the proxy says this is what to do. And the proxy should always be asked, even for mundane things, what would the patient choose? Which option they would choose? Would they agree with this? Is this decision compatible with the patient's values? That has some pretty interesting effects. It may sound a little like it takes a little more work. It actually really takes very little more effort to do that. One of the important effects is kind of strange in that it relieves a lot of the guilt from the family and from the proxy for being somehow responsible to make a decision about whether or not, and this is words of proxies oftentimes, I can't make the decision to kill my daddy. I can't make the decision to murder my father. That's the kind of language. Once you go down the road of the proxy's job is to tell us what daddy would want, not the job to make the decision. Part of the problem with that is legally, or at least from, I don't know about what, I'm not going to say it's legally required in most cases, but one of the things that hospitals do to minimize liability is to have lots of consent forms for people to sign, and we want somebody to sign that consent form, which again sends the message that they're not reporting as a proxy what the patient would want. They're being asked to sign a consent form making the decision, and that compounds the training issue and the untraining issue also. Ken, you want to comment on this?
Yeah, well, just a couple of grace notes. One of them is that we find The busy hospitals sometimes have trouble as they go through the proxy list. There's a flaw, and it's maybe hard to believe, but there's actually a flaw in Florida statute. It refers, in the case of both children and siblings, to a majority of them, which means, of course, if there's an even number and they're divided, you're just stuck under the law. I don't know why they didn't anticipate this, but I think we can all rest assured that the best minds in Tallahassee are working on this now. The challenge is all of them means all of them. It's much easier to appoint as proxy the daughter who the patient lives with, the oldest one, the loudest one, the most assertive one. And I think we probably share the same experience that one might tend to not be willing to listen to the team when the team is saying there's no getting out of this. They will not survive the hospitalization, and doing a bunch more stuff. By the way, it's not a zero. It's not like, well, what's the harm in trying? The harm in trying is, given our clinical judgment, someone you care about deeply will die, and he or she will die badly. And helping loving, loyal, grief-ridden proxies and surrogates manage that is among the most useful things we can do. This is where, when we talk about teams, we really mean teams. You need social workers and nurses and physicians participating in all of this.
Thanks. Next, let's look at the next case. Next slide. Ken, this raises the issue that we have here in Florida of the majority. And you see cases, and I've dealt with cases where there were seven siblings, and 3 of them want one thing, 3 want another, and we can't find the 7th. And it becomes a logistical nightmare that every decision has to be run through all those children. And that's not an uncommon situation. There's a lot of large families out there that have multiple decision makers. And explaining the issue to every one of those decision makers, and having them get on board, at least the majority of them on board with a course of action, can be extremely burdensome and time consuming. I know in our institution, this takes up a tremendous amount of time, especially the social workers who are trying to line that up. And especially when relatively urgent decisions need to be made. Just in the general run of things, it's not uncommon to take 2 or 3 days to find a proxy and to get in touch with them and to talk to them. And it's a very burdensome thing. There's no easy way around this problem. One of the things that we have to be wary of is and I'm often surprised that how often clinicians don't understand that you actually have to have a majority of, if you're down to the siblings level, a majority of adult siblings, or a majority of the children available. So it gets pretty complex when you have to round up all the brothers and sisters if they're the decision makers and have them make decisions. And then there's no easy solution, and actually no legislative solution provided if there's an even split among those. So if your 2 brothers are making a decision and they have to agree, it's just the bottom line. Oftentimes in the clinical setting, whoever they can reach first is the person that makes the decision. The other kind of problem that's often happens is when one of the proxies says, "Don't talk to my brother, they don't care," or they're not available, or they are in jail or whatever. We found that this sounds kind of strange, but we found that family members are not always reliable in reporting the availability of other family members or the interests of other family members. It does turn out that there are some families that are not perfect, out there where everybody talks things through. And that is not an uncommon scenario. Had actually we've had kids say that they were the only child. And when in fact there were multiple other brothers and sisters, and would say things like, don't bother contacting them, they don't care. And it turned out they did care. And it was easy to contact them. So you have to be pretty careful with this process. Ken, further comments?
Well, one of the points you alluded to is a very important one, and the next slide addresses this, is while we're asking them these questions and while they're answering, the need to be able to serve as a surrogate or proxy and represent the patient's wishes is not in itself an entitlement to ask for things that won't work. The law implies that it is, at least in some places, which is why, for example, you can't write a DNR unless someone agrees to the DNR, even if that's the wrong thing for the patient. So let's change the slide, Ray, and talk about your experience with requests for non-beneficial treatment.
So I titled this slide, I want everything done for my mother. So the way this works is that proxies, just like a capacitated patient, choose among available legitimate medical options, not just anything that they've heard about or read about in the grocery store or online. It's among the available legitimate medical options. And this is kind of an interesting phenomena. I suspect others have run into this fairly often, and that is when you get an ethics consult that, and the request is something along the lines of a provider saying, the family or the proxy wants me to do something that I don't think is medically appropriate and is not standard of care and not among the options. And there's a couple ways that plays out. One is the family, the proxy has heard this from somebody else, somewhere else. They have a friend that has a similar disease, and this is what happened there, even though it's not appropriate for this disease. And so somebody's pushing that. But more often than not, I've discovered that when I ask the proxy and they say, this is what I want to do, I'll ask them where they heard of this option. And the place they've heard of the option is from the provider that's taking care of the patient. And why is that? Well, the physician will often say something like, we could do this procedure, but I don't recommend it. We could do that procedure, but it's not really the appropriate procedure to do in this case. And part of it is the human, kind of the human inclination to point out, we thought of everything to try to do. Let me tell you of all the things we've thought about, but they're not really things that we can do. I'm trying to prove to you, though, that I've thought of every possible thing. The actual impact of that is when the proxy hears it is, you could do something, but you're choosing not to. And that upsets proxies. There's something you could do for my mama, but you don't want to do it. And that interpretation is pretty common. Even though the physician pointed out it's not appropriate in this situation, that's another way of, I'm not sure I believe you or trust you, or maybe we don't have good enough insurance or enough cash and you don't want to do it, but you could do it. And so that's a kind of interesting phenomena. My advice is you should not say things to family members that you're not going to do, that are not medically appropriate, unless they raise that issue. So how do you draw the line with inappropriate and non-beneficial medical treatment requests from those that are appropriate? Well, that's a kind of tough line to draw in some cases. Sometimes it's especially clear that the treatment that's a proxy is asking for just is not appropriate. But sometimes it's kind of a judgment call. And in those cases where it's a judgment call, the default is the proxy gets to make that kind of call even if you recommend against it. So how do you tell whether something's in that gray area? And the answer is, would some physicians do it? And if some physicians would do it, and they would do it without being penalized for doing something that is outside of standard of care, that means it's kind of in standard of care because some physicians are doing it and are not being disciplined for that. And that becomes a value judgment, even though the physician who is taking care of the patient might, in their calculations, say the risks are greatly override the benefits. So that's kind of the way you sort those out. The clearer standard of care is, the easier it is to say, here's the things we are not going to do and not going to even consider doing, and not even going to mention that we're not going to do to the proxy. So the better standard of care is delineated, the easier it is to sort those things out. Dr. Goodman?
No, I've already said more than I know. Time for the next slide. With this, one of the things that my institutions and others have adopted policies on non-beneficial treatment. In fact, Kathy Lively is working on a model one we're going to put on the FBN website to try and support institutions to say, if you're not going to do something because in your clinical judgment it's wrong for the patient, then it's hard to imagine why anyone would seriously argue that you should do it. Having a policy to support that is a very, very powerful tool, and we've used it with great success at a couple of institutions. We basically declare we will not do that. If you don't like that, that's fine. You're welcome to seek care at another institution. But we're not, I mean, you could put it more or less forcefully, and this is definitely not something you should say, but that blessed mother of yours, we're not going to beat her up so you feel better about having been her advocate. That's just wrong. And she's going to suffer, and it's not going to be appropriate. And we're going to actually be prepared to stand firm on that. We're trying to find whether or not, because this is something our colleagues worry about all the time, is there any additional liability there? And the answer to that so far seems to be no.
No.
Document why you do what you do. There are many things. I was explaining this to somebody earlier today. The difference between requests and refusals is fundamental in bioethics. If I'm your patient and I'm a competent, voluntarily acting, informed adult, and I say, don't do that to me, you pretty much got your marching orders. But think of all the things that patients or families might request, which are harmful, illegal, dangerous, not medically appropriate. And we don't do them all the time. It's only at the end of life that we think we have to crumple up and say, okay, do what they're asking to their blessed mother, because otherwise we're going to get sued. That is false.
Yeah. So it is important to remember there are treatments that some people would go, this isn't worth it. Others would go, I think it is worth it. Those kind of decisions are value decisions, and those properly belong to the patient or the patient's representative, the proxy. But if the benefits are so minimal or non-existent, that decision falls outside of that. I will note that in every institution, whether you have a futility policy or not, you actively refuse doing some things that patients request. You don't put a new heart in somebody just because they have a broken leg and say they want a new heart. We do that. Surgeons routinely say you're not a surgical candidate, and that means doesn't mean you couldn't do surgery. It means we think the success rate is so low that it's not medically appropriate to do that. And so that happens at every single hospital that we say we're not going to do something because it's not medically appropriate. Though place that liability becomes problematic is if we don't clearly explain that and document that in the medical record, as Dr. Goodman said. And also when we're doing a bad job of communicating our reasons to patients, whether they buy the family, whether they buy our expression, a good job has to be done of explaining it. One of the interesting things about futility policies always includes really good communication of explaining why something is medically non-beneficial. And so there's usually sets out a structure to make sure there's a really good explanation and that the treatment really is non-beneficial. And usually second opinions about that are in place. So it's not just a policy that says we don't have to do anything we don't want to do. It's much more interactive than that.
The point about surgeons is a really good one. When a surgeon says, not a candidate, I can't do the case, we don't ask her, what's your futility policy? But somebody else goes back and says, sorry, the only thing that might have saved you is this surgery, but it won't work, so we're not going to do it, having just talked to the surgeon. The family will say, well, but I want you to do everything else then. In other words, we are grappling this afternoon with the same issue we've been grappling with for decades, namely love, loyalty, grief, guilt, and the desire not to be dead. And that just continues as very basic human responses to this. And our ability to communicate gently and compassionately is probably the best way to address them. Not by saying, here's our futility policy, take a hike, but here's why. And to do that in a way that we sometimes think we don't have time for or otherwise. Good point. Thank you.
So the next case is the proxy with ulterior motives. And this is a situation, you can think of multiple examples of this. A proxy will agree to a recommended withdrawal of aggressive treatment, but only after the first of the month when the patient's Social Security check arrives. That very scenario comes up at least every few months. And it's from the hospital perspective or the physicians or case management perspective is something along the lines, you think it's appropriate to withdraw treatment, move to comfort care, but you're not going to do that because of $1,500 or $2,000 in Social Security money. In the meantime, we're going to spend $10,000 a day in the ICU. And that just makes the hospital administrations crazy over that issue. Another kind of scenario is, I never liked him, but I'll make healthcare decisions for them. That situation it sometimes comes up, especially when you name your spouse as your decision maker, and then 5 years later you find yourself divorced in a nasty divorce, and you forgot to change the surrogate form, and so now you're the decision maker. I have had there's a variety of these kind of scenarios, but I have had a patient say to me when I questioned them, asked them about, do you want to change your decision maker since that's who you're not married to anymore? And that patient, in fact, said, the reason I got divorced is because they were cold and unemotional, and that's exactly who I want to have as my surrogate decision maker, that won't be swayed by emotion. And I said, I guess that makes sense, but so you can't really presume that just because somebody's divorced that the patient didn't want them as a decision maker. I've been taking care of her long enough. She needs to be in a nursing home is another kind of thing, and that we can understand that there may be ulterior motives about the decision making there that rest with how this will affect the proxy and the family, as opposed to what the patient would want, what's in the patient's best interest. The legislature, when they put together the legislation about proxy decision making, not only came up with the ideal list of decision makers, but they didn't anticipate that family might make decisions based on their own personal interest instead of what's in best interest of the patient. And so there's not an easy mechanism from a ethics role to remove a proxy who is making decisions, except to say, I don't think you're the right proxy, or to say, your job is to make a decision that the patient would want, not what's in your own personal interests. One of the things that I run into, not infrequently, somebody will say, my father never would have wanted this, but I can't make the decision to withdraw treatment. And the issue becomes, what do you do? Do you do what the proxy says? I can't make that decision. Or do you go with what the proxy wishes of the patient are? So my general inclination might be to say, as soon as somebody says, this is what my daddy would want, is to respond, thank you very much, we've got the information we need. If they go on to say, I can't make that decision, that's really difficult, but your job is not to make the decision. Your job is to tell us what you just told us.
And that frees them of a lot of pressure from that. Defang that obligation. You're not the one making a decision. The patient is, or the team is making a recommendation. We just want you to nod your head at the right moment so that we can do the right thing for the patient. Ray, there are a couple of questions here I'd like you to answer because they're good. One of them is,
we'll try.
Can the family be encouraged to agree on a single representative?
So the answer is yes, and that often happens, but it doesn't necessarily relieve you of the job of talking to everybody else and informing everybody else. If it's a decision, the way it would work, if there's a particular decision that's being addressed and the rest of the family says, I want my oldest sister to make that decision, and everybody buys into that decision that it's okay for that sister to make, yes, that would be appropriate. Giving blanket authority to a decision maker is not simply done, and the reason is the same reason that we have a problem with a subjective standard of disclosure of information, of telling somebody what we think they would want. One of those other siblings may very well not want a decision made that they didn't even know was going to be made, and they would have legitimate grounds to object to that. Any family member that is a proxy, say you've got 4 brothers making the decision, any one of those brothers can say, I do not want to be a proxy. And we should document that. And then it would be a majority of the other 3 proxies. If 3 of those siblings say, I want the older brother or younger brother or the brother that dad lived with to be the decision maker, and advocate their authority to be a proxy, that would be all right. And then you would go with the proxy. But just on a mouthpiece of, I want my older brother to make that decision, this particular decision, they wouldn't do it. I think they'd have to say, I don't want to be a decision maker anymore.
We are actually moving along swiftly. There are some other questions. I want to get to them, but I do want to get to some more of this of what we have on our plate here. So I don't care if my mother has an AD.
So this situation is the patient has an advance directive. It's time to implement the advance directive. The patient meets the conditions for the advance directive. The physician says to the proxy decision maker, it's time to, the conditions have been met. It's time to follow the advance directive. And the proxy says, no, I don't care if they have an advance directive or not. They may say, I didn't know they had an advance directive. I don't like the advance directive. What are your obligations? And the bottom line is your obligation is to follow the advance directive unless the proxy has evidence that the advance directive is not what the patient wanted. Been doing this for a long time. I've only seen one example where the family came up with and had evidence for a reason why the advance directive shouldn't be followed. It's a pretty rare occurrence. So bottom line is the advance directive takes priority. The general role of a proxy when you have an advance directive is to clarify ambiguities that may be in the advance directive, not to overturn the advance directive or to supersede the advance directive, but to clarify that. So a clarifying decision by a proxy in an advance directive should be consistent with the spirit of the advance directive, not in direct opposition with advance directive.
One of the things, by the way, the law does point out, it's one of the things the legislature got right. If, for example, you're in a position to have a patient's advance directive, if you hide that from the hospital, that's actually a felony in Florida. The legislature's intent on insisting on what you just pointed out, advance directives govern. It's really hard to imagine a situation where, look, it's why we tell people update your advance directives. If someone could say, yeah, it's 40 years old and therefore not valid, well, then everybody's in a bit of a tight spot at that point. But the point of it is to be as explicit as possible. One more terminologic note, as you know, but to clarify for other people, a lot of the business of proxies would be eliminated if patients would, in an advance directive, appoint a surrogate. You can have 30 children, you can have 14 spouses, you can have one sibling. The point is the one you select to be your legally authorized representative then becomes your surrogate or the legally authorized representative. Doesn't matter how many children you have, how many siblings you have, and that sort of thing. And that's very important. We appoint proxies when our patients have neglected to do that basic civic duty, namely have an advance directive, which at the very least says who you want to be in that position if you lose capacity.
Another note about liability. It is at least legally debatable. We haven't had any cases on this, but it's legally debatable that if a physician knowingly disregards a patient's advance directive, they may share the liability just as if you destroyed and hid an advance directive. That is potential. The other side of that is if a physician, here's another thing that Chapter 765 got right, I believe. If a physician makes a good faith effort to follow the patient's advance directive, doesn't mean they have to turn out to be absolutely right in the interpretation of it, but if the physician believes this is what the patient would want, as evidenced by the advance directive, and there's no formal objection by a proxy that needs to be adjudicated somewhere, and they go ahead and follow the advance directive, they're in a legal safe harbor and immune from civil, criminal, and professional liability. And that's explicit. That's about as good a legal protection as you can possibly have from doing that. The reason the legislature put that in there is exactly because they didn't want physicians afraid of following a patient's advance directive because something might happen. Legally, criminally, or professionally. So that's really not an excuse of I'm afraid because a family member is objecting. Psychologically, it's pretty easy to understand why a physician would be hesitant when some family member is standing there saying, I don't care what the advance directive says, I want you to do this or I'm going to sue you. And on the other side of it is you have a written document and the patient's incapacitated. And so oftentimes someone will cave to that request, even if it's uninformed, even if they say, I don't care what my mother would want.
I've got one eye on the clock and we've got a few more things.
Okay, let's move.
Next slide, please.
So this is a pretty common scenario. We see this often with social work proxies. The patient will be in the hospital and no one will have called looking for a proxy or appointed a social work proxy because they're not doing anything. In other words, they're not doing a procedure that requires a consent form. Sometimes we see a case of a patient that's been in the hospital for a couple of weeks. They're now being discharged to a nursing home, and suddenly we have to find a proxy to sign the discharge papers for the incapacitated patient, and they never had somebody in there before. The bottom line is every patient has a right to leave the hospital and to decline medical treatment. And so even if you're not, quote, really doing any major procedures, you're still doing something to the patient by having them in the hospital, and they have to have their right to leave and refuse treatment at least able to be expressed. So every patient in the hospital that's incapacitated should have a proxy decision maker, a surrogate, or a social work proxy appointed. They should not be in the hospital for anything over a day or two, and that's pushing it, in my view, without a decision maker in place.
Well put. Next slide.
slide. So just a word about social work proxies. I think a fair number of hospitals now use social work proxies. That's a social worker that's been usually contracted with by a hospital, can't be a hospital employee, a social worker who can be appointed to make proxy decisions for a patient in the event that you can't find anybody on the proxy list to make decisions. See a fair amount of this in Florida, of people that literally don't have anybody to make decisions for them at the end of life. I find these especially tragic situations. One of the things that has a role of actual official role of an ethics service is you have to vet the proxies that are going to be used, and then you have to review. Somebody has to kind of sign off that the proxy is appropriate, that a search has been done. And then if any end of life decision is made by a proxy, social work proxy, including resuscitation, that's considered an end of life decision, that has to be reviewed and approved prior to the implementation. So you can't write a DNR order on a patient with a social work proxy until your ethics service reviews that decision and agrees to it. So there's some resistance from people who've never utilized a social work proxy. In my experience, they're like the perfect proxy that doesn't know the patient but can make best interest decisions, because they usually have a lot of experience working with patients and families, and they understand the medical issues, and usually make, in my experience, always make really good decisions, thoughtful decisions. And the ethics service works pretty closely with those individuals. Most social work proxies that I've interacted with are retired social workers who have 20 or 30 years of experience in working with patients, and are very thoughtful and take their role very seriously.
Ray, what I'd like to do, we're moving swiftly here, but I do want to acknowledge a couple of colleagues that put comments in, and I want to flag one of them and ask you to comment on it. This is from our colleague Pat Corrales at the at Miami VA, University of Miami. I understand and support shared decision-making based on what the patient would have wanted and or in the best interest of the patient, but are providers still required to offer or be made to provide, this goes back a click, non-beneficial treatments just because the proxy or patient demand it? Why do statutes still require to do CPR if it's not going to work, or change outcomes? Are we still doing slow codes out of fear of liability? Another comment was to that effect. It's what the social worker, the proxies that serve in this role eliminate that problem. They will listen to reason, whereas sometimes family members don't. But if you could respond briefly to Dr. Corrales's question.
So the bottom line is, no, you don't have to. If somebody's making a decision or making a request for something that's outside of standard of care and is non-beneficial, and it's documented appropriately, no, you do not have to follow that. The resuscitation issue is a special, kind of a special category. The default is that anybody that dies in a hospital, you try to resuscitate. And that's just kind of a long-standing default. I think that's an inappropriate default unless the decision has been made to not do that, to not offer resuscitation. There's a couple kind of asterisks next to that. A physician on site, if a patient arrests, can make a determination that resuscitation is not appropriate. They can't do that ahead of time, but they can make that decision at the time of, if you want to start it and it's not working, you can stop. If you don't want to start it, then that's in the realm of things you can do, but you have to be there on site at the time to make that decision.
In other words, if you're a physician at a bedside and the patient is otherwise full code, but in your clinical judgment, CPR is wrong for that patient, if you're able to write a DNR, then you don't have to run a code. Use your judgment at the bedside. Would you agree with that?
Yes, you just can't do it. You can't do it ahead of time because of the very nature of that. A fair number of times, this is a direct result of not having the conversation until way too late. If a patient says to you, I don't want to be resuscitated, and then the proxy after the patient becomes incapacitated changes that, wants to change that, that's really, you do what your patient says, just like that's a verbal advance directive that you follow in spite of what the patient says, unless the medical condition prognosis has significantly changed to the point that the patient would have never anticipated this current situation. That would be
hard lift. Can we do the next slide, please?
So I think, Ken, you've already talked on this quite a bit. I'm a big proponent of naming a surrogate. And unfortunately, as Ken pointed out, we often choose the wrong surrogate. Parents often choose the son or daughter that will be the biggest problem if they don't choose them. And so that's a family issue. The catch would be is that the surrogate should be somebody that's available, they're willing, they know the patient's values and wishes, and they can make the decision the patient would want. So you should not name a surrogate that doesn't tick all those categories. When the role of the physician is really important in this conversation, and it's a much easier conversation than about a living will, where you have to explain all the ambiguities with what terminal means or end stage or persistent vegetative state. This is pretty straightforward, but it shouldn't just be a conversation that says, who do you want to make decisions for you if you're unavailable, if you become incapacitated? It's got to be, are they available? Or do they want to do it? Have you talked to them about it? Let's make sure they know they're in that role. And are they knowledgeable? We routinely run into somebody that's named a surrogate. We call the surrogate up, and it turns out the surrogate is the next door neighbor who pulls the garbage can of the patient up to the house, and they know nothing else about them except that it was somebody that was sick and lived next door, and they suddenly think they're now the surrogate. So it's important to have that kind of conversation, and it ought to happen earlier, not later. By the way, a surrogate can be verbally asserted. You don't have to have a signed document. Sometimes people don't want to sign something, and all they have to say is, I want this person to make decisions, and it's up to us to drag some witnesses in to hear that, and then to document it appropriately in the medical record.
Hopefully. Next slide, and then we will wrap up.
So this raises the issue, the last issue that just mentioned is the issue of whether somebody's terminally ill. A proxy cannot make an end-of-life decision, including do not resuscitate, for an incapacitated patient unless two physicians have evaluated the patient and determined and documented the patient is terminally ill. That needs to be in the electronic medical record. The physicians have to understand that they're not making, if you will, they're not making a decision whether a patient is terminal or not. Their job is to determine whether the patient meets the legal definition of terminal. That's quite different. It's not asking them, do they personally think the patient is terminal? It's not a personal definition. It's whether they meet the legal definition. In Florida, unlike some other states, the legal definition is quite broad. And it's a long discussion to kind of go into why it's quite broad. But the bottom line is people have a right to refuse any kind of treatment, and you're not supposed to lose any rights when you become incapacitated. And the only way to accomplish that, to avoid a restriction of your rights when you're incapacitated, is to make the definition of terminal broad. The other solution would be just to drop that as a requirement for requests. But the legislature thought that was not a good idea.
We terminal or end stage, by the way, which has a similarly broad definition as regards the question of non-beneficial care or even futility, that the legislature acknowledges that a patient might have an end stage condition is encouraging in this regard, because the definition of end stage is, in essence, you're going to die no matter what we do. That's the three criteria: terminal, end stage, and persistent vegetative state. So there is some legislative recognition that if someone's going to die no matter what you do, why on earth would you be compelled to do it? Which is why some lawyers are comfortable with non-beneficial treatment policies, which say if the patient's terminal and end stage, on the basis of what does that constitute an entitlement to demand that a learned health professional do stuff that she believes will not work?
So oddly enough, Ken, to kind of wrap that part up, is the reason end stage and persistent were added in addition to terminal is precisely because physicians were using their own personal definitions of terminal instead of a legal definition. And the thought by the legislature would be, let's add a couple of other things that maybe physicians won't know what they mean and will read the definition. I argued in front of a legislative committee that was a futile gesture, but
how's that working?
And in fact, it's just made the world much more complex, not easier.
I think we're good. Obviously, this is a conversation we wanted to have because we're mindful of the fact that if you run a hospital in Florida, you are dealing with this on a daily basis. I want to draw things to a close. Ray, thank you so very much.
Thank you.
I don't know about you, but I actually had some fun for a change. And I want to thank our other presenters who are still here. I see Kathy and Laurel. Thank you again very much. And then especially to you all. You've joined us here for our 32nd annual program designed to support health professionals who are struggling, learning about, grappling, and trying to do a better job addressing ethical issues. It's been a privilege to be able to join you. Shout out again to our institutions, the University of Florida, the University of Miami, and Shands and Jackson for their unwavering support of these initiatives. On that note, absent anything else for the good and order, thank you. Check the website every so often. The FBN is evolving, and we're trying to make it as nimble as possible to support the missions of networking and professional development. On that note, thank you. In a world in which there's a lot to disagree with and a lot of conflict and a lot of just plain nastiness, what we hope to have accomplished well through the FBN and through these activities is the demonstration when we're at our best. We're pretty good at collaboration, cooperation, and making things better for the people we say we're serving, namely patients. Thank you and goodbye.